Good afternoon, everyone. Good afternoon to the panelists, attendees, and guests. I'm Dr. Ratna, and it is my absolute pleasure to welcome you to the World Stroke Day event 2021, jointly organized by Dakshama Health and Indian Stroke Association. Stroke Support Alliance, the initiative that we are undertaking currently and that is jointly organizing along with Dakshama Health and Indian Stroke Association, is an initiative led by us trying to bring the voices of stroke survivors and carers, as well as the healthcare ecosystem together to prevent, manage, and treat stroke in a more holistic way. Patient advocacy is not new in India. We have seen great movements led by HIV positive networks, cancer survivors, and rare disease parent groups. However, the patient voice in stroke has been relatively low, and Stroke Support Alliance is our attempt to bring the stroke survivors and families to the mainstream of patient advocacy. Today's session has two great panels and three keynote speakers. The discussions will dwell on all aspects of stroke care, from prevention to management to rehabilitation, and even reskilling and reintegration of survivors into society. We also have two announcements. We have a video that has been made by stroke survivors themselves, and the announcement of scholarships for caregivers of stroke survivors for reskilling or upskilling their existing skills. Without much ado, I would like to invite on stage our first speaker, Dr. Jayaraj Patel. Dr. Patel needs no introduction. He has had an illustrious career and he is very well known in the stroke world. He is currently the principal and professor of neurology at Christian Medical College, Ludhiana, Punjab, the vice president at World Stroke Organization, and the president at Indian Stroke Association. He is also the chair at the Asian Stroke Advisory Panel. He has numerous awards and publications to his credit, the most important being the recipient of the Global Stroke Services Award 2020 by World Stroke Organization, and the first Asian to receive this prestigious award. He was the Congress co-chair World Stroke Congress 2016, and his special interests lie in stroke care services, stroke trials, and systems of care. He is widely published author on stroke systems of care, epidemiology, and rehabilitation in low and middle income countries. The floor is yours, Dr. Pandyan.
Thank you, Dr. Ratnadevi. I sincerely thank Dr. Ratnadevi, CEO of Dakshyani and Amravati Health and Education Group for organizing this Stroke Support Alliance, for bringing in the civil society engagement for the stroke survivors. This will really strengthen the national stroke guidelines through the patients and patient groups view. And it is very, very important to bring in patients' perspective into the management of stroke in our country. There has been a tremendous advances in terms of stroke management. Probably I would say the last 2 decades or so, but it all started in 1995 when the groundbreaking clinical trial on acute thrombolysis, which was a positive trial, which was published. And after that, the health system slowly was able to deliver that particular therapy. Even in US, it took about 7 to 8 years for them to make it as a routine practice because there was so much of gaps in the health system to adapt to that new treatment modality. And in 2008, the period from 0 to 3 hours to 0 to 4.5 hours was approved, and with multiple trials. And the most important landmark breaking research was in 2014, the first trial on using stent retrievers to remove the clots in the brain, mechanical thrombectomy. And then after that, the next 4 years, flurry of positive trials with treatment effect never seen before in any of the diseases and the interventions. But the health system is not ready to take it because even in developed countries, the number of eligible patients who receive thrombectomy is very low. And even thrombolysis is also very low because there are many issues in the stroke systems of care. For India, if you look at the stroke systems of care, starting from pre-hospital, bringing the patient by ambulance to the emergency department, and then from the emergency department to the scanner, then to this imaging to the stroke unit, and whether patient is eligible for thrombolysis or endovascular treatment, stroke unit management, early rehab, and early supported discharge, rehabilitation, and community support. But there are only few countries in the world you have this entire systems of care integrated. When a stroke patient goes to a hospital, gets the right treatment, and they leave the patient to their homes or to nursing home, depending upon the disability that they have. In India, in each workflow, there are issues like whatever we call as gaps. So one gap is the ambulance services. In India, we don't have that culture of calling ambulance, unlike overseas. And ambulance crew are not trained in recognizing stroke in the community. When you come to the emergency department, we don't have an emergency department or a specialty on its own. Not only the NMC has put in place, it's mandatory from 2022, every medical college needs to have an emergency department with a qualified staff. Then you have a radiology, the CT scanner, imaging. In big cities, as you have hospitals with CT and MRI facilities, but in district level hospitals, there are maybe 40-50% of the district hospitals in each state have CT scanner, which is the important thing for the diagnosis of stroke. And stroke units, largely in private sector, but slowly it's coming up in state government hospitals. You will see this from many of the panelists who will be discussing today. And rehabilitation is another area where it is fragmented. And as healthcare professionals who are interested in stroke care and improving stroke care in our country, we have done over the years all sorts of advocacy, but we don't have a support from the patients group. And from World Stroke Organization, we have a separate SSO, Stroke Support Organization, under the umbrella of WSO, and there are dedicated board of directors for that, and also a vice president who was elected from the SSO. So there's so much happening at the international level, but in India, it is just the beginning. Today, it's the beginning, I would say. There's a great effort of Stroke Support Alliance, and we are going to see more and more patient involvement, not only in developing stroke care in our country, but also research. We have a India-UK collaboration. When we wrote the grant, even before writing the grant, we had to go to the patients and ask what is the priority in terms of treatment when you go to the hospital. What do you want, and what are the areas you want to do research? So even we need to bring in patients into our in planning the research priorities for stroke. And I'm pretty confident that the discussion that will happen today will and there will be a lot of points that will come up and emerge, and we could incorporate into the national guidelines for stroke, and that will be very authentic, and it will be very powerful for the advocacy, particularly to involve the policymakers, not only in the central government, but also in each state governments of our country. So on behalf of ISA, my best wishes to the entire team and also all the panelists who will be taking part in the discussion. Thank you. And may I have the video, please?
I am Geeta.
I am Jitendra.
I'm Sarak Kumar.
I am Kamran.
I am Ashish.
My name is Varun.
I am a stroke survivor.
I'm a stroke warrior.
I am a stroke warrior.
And I am a stroke warrior.
I am a stroke warrior.
And I am a stroke warrior.
B stands for balance. Is the person having difficulty in standing, walking, or maintaining balance?
E stands for eyes. If a person having difficulty in the vision, if he or she is having blurry vision or black spot or unable to see at all,
F stands for face. Is one side of the face dragging down? Is the smile crooked? And is there drilling of saliva, or is the patient unable to hold food in the mouth and food is dropping out?
A stands for arms. When the patient is not able to lift one side of the arm, unable to walk or stand due to feeling of sudden weakness in hands or legs.
S stands for speech. Is the person's speech difficult to understand or coherent?
T stands for time. If you see any of these signs, reach to the nearest stroke ready hospital. Golden hours are 4 hours with advanced treatment up to 6 hours.
Don't be the one. Prevent stroke.
Don't be the one and prevent the stroke.
Don't be the one. Prevent stroke.
Don't be the one, prevent stroke.
Don't be the one, prevent stroke.
Don't be the one. Prevent stroke. I am Geeta.
I am Jitendra.
I'm a Sarak Kumar.
I am Kamran.
I am Ashish.
My name is Varun.
I am a stroke survivor.
I'm a stroke warrior.
I am a stroke warrior.
And I am a stroke warrior.
I am a stroke warrior.
And I am a stroke warrior.
B stands for balance. Is the person having difficulty in standing, walking or maintaining balance?
E stands for eyes. If a person having difficulty in the vision, if he or she is having blurry vision or black spot or unable to see at all.
F stands for face. Is one side of the face dragging down? Is the smile crooked? And is there drilling of saliva, or is the patient unable to hold food in the mouth and food is dropping out?
A stands for arms. When the patient is not able to lift one side of the arm, unable to walk or stand due to feeling of sudden weakness in hands or legs.
S stands for speech. Is the person's speech difficult to understand or coherent?
T stands for time. If you see any of these signs, reach to the nearest stroke ready hospital. Golden hours are 4 hours with advanced treatment up to 6 hours.
Don't be the one. Prevent stroke.
Don't be the one and prevent the stroke.
Don't be the one. Prevent stroke.
Don't be the one, prevent stroke.
Don't be the one, prevent stroke.
Don't be the one. Prevent stroke.
Good afternoon, everyone, once again, and welcome back to our panel discussion. Our first panel will delve on the issues of stroke management and prevention need of the hour. The panel will be chaired by Dr. Shirish Hassak, and we have 5 panelists: Dr. Padma Srivastav, Dr. Arvind Sharma, Dr. S. Sundar, Dr. Bipin Gopal, and Jitendra Varshne. We are just awaiting Dr. Hassak to join us back. He has had some technical issues. Meanwhile, I will go ahead and introduce our chair. So Dr. Sirish Hastak is the Regional Director, Neurology, Stroke and Neurocritical Care at Global Hospitals, Mumbai. He was also the past president at Indian Stroke Association 2010-2011. He has a qualification of MD Medicine, DM Neurology, and a stroke fellowship from Canada. He set up the first stroke unit in Western India and also set up the first stroke helpline in India. He is the Rotary District Chair for Stroke Prevention in Mumbai. He has won the Economic Times Inspiring Neurologist Award in 2018 and the Top Neurologist Stroke India Today Award in 2019. He has had multiple national and international publications and is a well-known person who has taken very unique ideas like training, say, people from ambulance drivers and first care responders, so that people who actually suffer from stroke reach the hospital on time. I'll just give him 1 more minute. I see him joining. Meanwhile, what I can do is to lead you through the topics that the panelists are going to cover today. So Dr. Sirish Hastak will lay the background on what stroke management and prevention involves and why it is important in the context of India, both in the urban and rural areas. Dr. Padma Srivastava will cover the journey of stroke care in India and how it has evolved in the last decade and in the last 10 years. Dr. Arvind Sharma will speak about the digital changes that have come in the country. Can digital change the narrative? And we have seen that very much in the context of the pandemic, how telemedicine and telehealth have played a very large role. Dr. Sundar will speak about the innovative models of stroke care in India. Dr. Bipin Gopal will talk about translating national guidelines to a shared understanding of prevention and stroke. And Jitendra, a stroke survivor, will cover the issues of what the patient really wants and is his voice really heard. Dr. Hastak, I can see you online. Are you able to hear us? Dr. Hastak? Dr. Hastak, over to you. I just introduced you.
Okay, you can see me?
Yes, we can see and hear you clearly.
I'm sorry, I apologize. My laptop has given up at the last moment, so my laptop had a stroke. So I'm sorry about that.
No problem, sir. Over to you. And for your opening remark, you could go ahead and introduce the speakers.
Sorry, Arvind, and sorry, all of you. My laptop gave me some trouble. But anyway, I think I've moved in with my phone, so I'm okay. Yeah, thank you. And thank you, Dr. Ratna, and of course, Tamanna, for giving me an opportunity to share my thoughts about stroke care with you all. And of course, thank you for the Stroke Support Alliance, which I think is going to be a key to bridge, this patient-doctor gap. Because I think this patient-doctor gap exists. And I think Arvind and Dr. Padma and all the panel members will basically agree with me that we need to bridge this gap. So thank you for being like a gap minder organization, So minding the gap between the doctor and the patient. And I think we need more gap minders like you, Dr. Ratna and Tamanna. And I hope that the Indian Stroke Association, of course, is supporting you, and this Stroke Support Alliance, I hope that it goes ahead and bridges the gap between the patient and the doctor. So I think welcome to the panel, everyone. I hope you can hear me clearly and you can see me all right, Arvind? Yeah.
Yes.
So I think we'll go ahead with the panel, the discussion on stroke management and prevention. Of course, it's the need of the hour. I will just give a brief overview and then hand over to my esteemed colleagues who are on the panel. So stroke management, friends, essentially is like a hospital, post-hospital phenomenon. And so I think, we won't touch in this panel. Probably it looks like I may not touch too much of the pre-hospital part, but we'll try to touch the hospital and the post-hospital part of stroke management. But all three phases remain important. And as Gapmind does, I think, the Stroke Support Alliance will probably have to look at all three phases: the pre-hospital, the hospital, and the post-hospital phase of stroke. Now, if you look at stroke management, of course, it's also extremely time-dependent factor. So the acute phase of stroke, the subacute phase of stroke, and the chronic phase of stroke. And, as the arrow of time changes, our goals change. And so in the acute phase of stroke, our key goal is to reduce brain injury and treat the complications of stroke by an urgent commando approach, which I think Arvind and Padma and are very, very much updated on and would give you their ideas on the commando approach to stroke. In this phase, of course, time is brain, and it's an important concept that you don't lose your brain. Of course, utilization of the brain of the relatives and of the doctors is as important. So I say, doctor's brain used in time and relatives' brain used in time is equal to patient brain saved in time in this commando approach. So yes, in this approach, of course, we have that 4.5 hours classical window. When I started off neurology practice, stroke practice, it used to be 3 hours. Then it became 4.5 hours. Then the mechanical clot retrieval window came at 6 hours. Then it went to 9 hours and 16 hours. So, and then of course now 24 hours. So I hope it becomes 48 and 72 hours, Arvind. So we look forward to that as well in the future. And I think some of these things are going to change. So we have the IV thrombolysis window, which is 4.5 hours. And then we have the mechanical clot retrieval window, which is 24 hours. But it's very important to stress on the fact that 4.5 hours doesn't mean you wait for 3.5 hours and come to the hospital. Or the 24 hours window doesn't mean that you wait for 16 hours at home and then come to the hospital. So it's very important for us to impress upon you all that come quickly as soon as you recognize a stroke. And of course, recognition of stroke is important. And we already released the Be Fast video, I think, for everyone to see. The other part which is important in the acute phase is the complications. And I think the complications of stroke be like infection, venous thrombosis, electrolyte imbalance, dehydration, and cardiac disturbances. So all these complications also lead to a lot of morbidity and mortality as well in the hospital. These usually happen in the first week to 2 weeks of the acute stroke. Here we have to stabilize the blood pressure, the blood sugar, start the rehab plan in the acute phase. One of the key things I think you need to emphasize upon is the code stroke activation. So I think hospitals should have a code stroke activation intra-hospital if they are admitting stroke patients to their hospital. And also should probably look at their own times about what are their times of door to needle and door to imaging. Because, a lot of hospitals say we do everything in 30 minutes. And unfortunately, when you actually look at their times, they may be 1 hour, 30 minutes. So I think, looking at yourself is a key to improvement. And I think we should insist on this. Of course, in this area, rapid imaging and rapid decision-making is important. The phase 2 and 3 are the subacute chronic phases of stroke, where you need to find out what caused the stroke, where did the clot come from? Did it come from the heart? Did it come from the aorta? Did it come from the arteries in the neck? Or was it because of small vessels in the brain? Or was this clot because of some clotting problems in the blood? And this, I'm talking about ischemic stroke. Friends, most of my talk is based on ischemic stroke. I will touch upon intracerebral hemorrhage, but I think at this point, I'm talking more of ischemic stroke. Based on the cause, you need to start in an ischemic stroke, antiplatelet, anticoagulants. Yeah. So based on on what you find and what is the mechanism of stroke, ischemic stroke, I'm emphasizing the word ischemic stroke, you need to start antiplatelets or anticoagulation or statins or antihypertensives, antidiabetics. So, I like to think of them as anti-stroke medication. Your discharge card, and this is another thing I think you should emphasize upon, the gap. Then I find that discharge cards of good hospitals will not tell you the mechanism of stroke, or will not say that this is fully investigated for the mechanism. And so I think this is important. So if you have a cardioembolic stroke, I think from the heart the clots have gone to the brain, you need to put in that this is a cardioembolic stroke. If you have a large artery disease, you need to put into your discharge card. And I think this is another thing we need to improve upon, to put the mechanism of stroke. The other thing I need to emphasize a little bit upon is if you have an intracerebral hemorrhage, of course, the things change quite a bit. Time is brain is not that critical an issue in an hemorrhagic stroke. Of course, you need to treat these patients in time. And of course, you need to look at these patients also carefully. But again, you need to know what is the cause of the hemorrhagic stroke. Was it because of blood pressure? Was it due to aneurysm? Was it due to AVM? Was it due to anticoagulation? And of course, set in a plan for neurosurgery if required, and also put in the rehab plan in place, which is true for ischemic or hemorrhagic stroke. Put in the rehab plan, put in the physiotherapy, speech therapy, occupational therapy, coordination plan. After this, I just want to end my talk by saying that the World Stroke Organization has put forward the post-stroke checklist, which I think is another good area to cover up for the gap minders, for us to bridge the gap between quality care for stroke that is lacking. And we have to be honest about this. The one thing that is important in the post-stroke checklist is secondary prevention. So is the secondary prevention in line with the mechanism of stroke? So is it antiplatelets? Are the anticoagulants given? Are the statins given? Have you given the antidiabetics and covered the patient completely? The second part of the post-stroke checklist is the activities of daily living. Record them. Mobility is to be recorded. Fourth is spasticity. Record the pain, record incontinence, record the ability to communicate, the mood of the patient. And the mood, I think, sometimes is completely missed. We have seen, and I think all of us have seen patients who are severely depressed and not being on any antidepressants and not being treated effectively. The cognition also has to be put in. That's the 9th part of the post-stroke checklist of the World Stroke Organization. What is the quality of life after stroke and relationship with the family? I think with this, I end, and let me introduce to you the speakers on the panel. I think, Dr. Ratna, have you already introduced the speakers? Or should I quickly introduce them? Is Dr. Padma there online?
Yes, she is there online.
I am here.
Hi, Padma. Okay, good. So you're right there. So let me introduce Dr. Padma, who is a personal friend and a great person. Dr. Padma Srivastava is the professor and head of Department of Neurology, Chief of Neuroscience Center, AIIMS, New Delhi. And she has been awarded the Padma Shri by the President of India in 2016. She is passionately interested in stroke medicine and has successfully helped bridge gaps in stroke care in India by innovative low-cost care. And one of them I know very well is the Telestroke model, which she has developed in Himachal Pradesh. She's a personal friend and an extremely pleasant personality. I think rather than me introducing everyone, should we go ahead with Padma's talk, and then I will introduce Arvind? So Dr. Padma, Journey of Stroke Care in India. Can we go ahead with that?
Yes. First, thank you, Shirish. God bless you. I hope we do meet in person sometime soon. And thank you, Dr. Ratna and Daksham, for giving me an opportunity to connect with you all. I can see Dr. Gopal there. I hope you're okay, sir. And so I'll just tell you a story about the journey, because there's one thing I feel that before, in my lifetime, if I could actually contribute something which would actually change for the good, for the benefit, for furthering the stroke care in the world. I mean, in my country, it's a mission accomplished. So if you look at the healthcare delivery system in the country, we have a 3-tier system, and it still exists. So you have the primary health care, you have the district level, and then you have the tertiary care. So the tertiary care is where most of us do come in. So although they're sprinkled all over the country, so you have conglomerations in the urban settings. And you're at district level where, Dr. Gopal is so well versed with, where, there's a huge geographic differences between different parts of the country. You can't compare Kerala with other states. And then you do have the primary health care, which is essentially manned by healthcare workers. It need not be always the allopathic doctors. Said that, when we're looking at the stroke statistics and the theme for this World Stroke Day, when we're saying that time saves lives and every minute counts, and then you have this thing about the entire stroke chain. So you want people to know what stroke is and present to you in the right time. And then you also have the delivery system that when they coming to the emergency, your machinery should be well oiled to not waste those minutes. So it's not just that the public awareness that they need to recognize and they reach out to you, but once they enter a healthcare delivery system, the mandate is also amongst us not to waste the minutes when a patient comes in, right? And is that system uniform, optimal to having the best stroke outcomes across the economic, social, and geographic barriers across the country? It's no. So in the year 2013, when there were initial stroke guidelines for the Ministry of Health and Family Welfare, and they needed to, in fact, I was also an author, I believe, sometime in 2009, and they were continuing till 2013. And we had a relook at the guidelines and all. There were so many issues which sort of were in your face, and that could be tweaked. You didn't need huge change in infrastructure. What it needed change was the attitude and the aptitude to do the change. So then in April 2014, as Shirish has mentioned, that we started this project in a small little state of Himachal Pradesh. The reason here was that if you are looking at the stroke patients to be treated by neurologists, it's no-brainer, because you have probably right now, Arvind could correct me, but I don't think we are more than 3,000 neurologists for a 1.3 billion population and counting. So very soon we'll have another Australia added on to our population. And so that ratio and that kind of inequality in terms of how many neurologists will be needed will never be met. And forget about it. We don't need that. So we need to get the physicians into the umbrella, the mandate of managing, when they are managing the golden hour of trauma, golden hour of delivery of a child, and the golden hour of a myocardial infarction, so that we have a golden hour of stroke. So we have the concept of a stroke physician, which doesn't exist in India. We don't have a course, and it doesn't exist even in national boards of examination. We don't have a certification to say that a person is a stroke certified physician. Said that again, we tweak. We are very good at jugaad. So then we said we can have this standard operating protocols, which can be simplified to minimize the bugbears of complications if such a system can be employed by a physician. And the physician can be an orthopedician, can be an ENT surgeon, can be an obstetrician, anyone who's manning the emergency at a district level, because the strokes can happen all over the place. It's not going to happen in around Ames or Sri Chitra or what have you. They will happen in Timbuktu, where the closest healthcare delivery system will be a district hospital. So that was the first mandate. And what kind of an infrastructure? Well, Telestroke was not a high-end thing, no rocket science. That's not going to be tenable for a developing world, but India is a prototype. So we used a WhatsApp model, published it, seemed fine. And then we went on, and Dr. Gopal would tell you that how much they built up on that system. And Kerala is now the torchbearer for, I think, the best way of delivering an optimal stroke care. And this we have employed in various states across the country. And if Dr. Gopal would remember, I did visit Kerala. At that time, we used the Director General, the IG Police, Mr. Behra. He's still there, Mr. Loknath Behra, and we got the Health Secretary, and we had the first meeting with Shailaja, and then it was history in Kerala how they took it forward. But the same thing didn't span out the same way. A lot of states didn't go the last mile. They didn't even reach the last mile. And it was there. And I suppose that is because of, again, the huge variations and well, the uniqueness of the geographic situations. So we have a large country, and you can't equate the language, nor the the beliefs, and also what is already existing to the percentage of literacy and education at various levels. Said that, so we have the awareness, and I'm sure the awareness programs are going on, and you have the BFAST, as Shirish has said, translated into different languages. I've just seen that the thing that every minute counts and time saves lives. This year's theme has been displayed in all district hospital levels where literacy is high. They would understand and they would reach out. In fact, they would ask for that particular management. Right. But when they do reach the emergencies, then you have the physician who should be equipped with the knowledge and also the confidence to give it. Second, you need to have the drug available on the shelf, and that should be included into the emergency system of medicine, and also the essential list of medicines. And that has been possible, and that has been listed now. In the year 2015-16, we got the thrombolytic drug enlisted into the essential list of medicines and also the emergency system of medicines. So that's there. And in a lot of district hospitals now, it's on the shelf, and now we have 2 thrombolytic drugs, and at least one of them has a shelf life of 3 years. So you can have it on board and you're not rushing for a drug at that point of time. So that was one sort of a small one, and that needs to go on. The second part of this journey was that the tweaking of the guidelines, and this was published in the year 2019, and the latest guidelines are going to come out in this year 2021, and there is a serious the exercise which has gone into it with both the DGHS machinery as well as the Ministry of Health and Family and Welfare machinery, looking into the existing guidelines and what could be tweaked in that. For example, tenitic places in it, and the dosage is now going to be modulated from 0.2 to 0.25, and things like that, which would give you a legal sanction to do so when you're delivering this system. And then we have not just in the acute care, you have the role of NOACs and also where all, and in the CVST and so on and so forth. And then the third thing that has been put forward, and I think the COVID pandemic also has taught us a lot of new things. In fact, I would think that there is an EC and a BC, that is after Corona and a before Corona. So we have really gained a lot of insights into living and life in general, and what is prioritization and what is important. So in this era, we've realized that strokes have been integrally, in a sense, into COVID, post-COVID, and also the management protocols in the COVID pandemic has also taught us a lot of stuff. And in March 2020, there was this meeting held in my institute in director's boardroom, wherein the board, which was looking after the MCI and now of course is NMC, they met and they gave the legal sanction to Telestroke, the telemedicine as a module, and the spin-off was Telestroke. And that gave a lot of legal sanction to at least some part of the care of delivery, and that has been in fact tweaked in several ways across different practice settings. And currently, another venture as part of ICMR venture, now they are coming out with the newer part of what are the guidelines, wherein telemedicine can be applied to Telestroke, to also the diabetes care and cardiovascular medicine. These 3 big areas, these guidelines have been framed and they're due for publication, and that will give us also a lot of impetus in carrying forward the telemedicine aspect of Telestroke in terms of both acute, as terms of prevention, primary, secondary, and rehab. And then the last part is that when we look at the rehabilitation part of it, we can't probably compare with an extremely high-end assistive devices. They're important, and it's phenomenal where the world has progressed in terms of assistive devices in helping out a disabled person regain that function, get integrated back into the society as a useful member. And that's is important, not in terms of how much is my score of MRS going up. It is in terms of how can he get his right hand back in action? Will he be going back into being a person who's earning the livelihood? And especially since we know we have 1.8 million strokes a year last year, and 25% is stroke in young, less than 40 years of age. And you can look at the burden, which is gargantuan in numbers. So said that in assistive devices, two things have come into the journey. One, getting our IITs involved. So you have a lot of biomedical engineering aspects of IITs. Now we have a collaboration with IIT Delhi, and we've got out the prototypes of a hand exoskeleton. And there's IIT Kharagpur. There is a vision appliance for the loss of vision, and a lot of trust. And also, there is a high-end, the top-down approach in getting the assistive technology, which is more India-centric, geographic specific, low cost, again, being, getting into sort of a project which can hand out low-hanging fruits, which can be translatable to the industry and get out those appliances which will come down into the general public soon, and not as a publication. Now, publication is not the kind of a goalpost. A goalpost is actually something which is there in your hand to be used into the delivery of stroke care. Now, that's another important thing which has come into the journey of stroke. And of course, the other aspect is getting the holistic part of it is also applying our own, traditional systems, which includes a lot of push for Ayush, a lot of push for yoga, which is also being integrated into the holistic capsule, which can then be, and we understand that the indigenous, the traditional systems are much more there percolated down, and they're going to be also geographic centric. Like, Ladakh practices something else. And I know we hold the health camps in Ladakh every year, and we know what systems work there and who listens to whom. Now I go there with my cut hair. I look like a Ladakhi too. Incidentally, my name is also Ladakhi, so they do accept me. But said that though, me saying something, and if I say that please don't drink Ladakhi chai, versus their own armchi telling them, don't drink Ladakhi chai. And if you have to drink Ladakhi chai, don't put the dollop of salt and butter into it. So that makes sense. They listen. They would approve of that advice, as against coming from some person they do not think it's their own. I'm an alien as far as, that. So you have to integrate the local practitioners and empower and give them that necessary importance and impetus. Don't treat them as something which is different. Remember, every science has a value, and it is when practiced with authenticity, because there are quacks all over. But the science is very, very powerful. And we have the science of Ayurveda, we have the science of yoga, we have the science of our own systems, which you amalgamate and empower the practitioners who do that as well, and get into, that's what China does. And that we know there are a lot of countries where you use their own systems, and it's high time we did. And we get into an open frame of mind where we all work together. And that's also another thrust which has come into this journey of stroke. So I think, I know there are miles to go ahead, but I think in the journey of stroke, a huge thrust I see in the last 5-6 years, in wherein there has been a sea change, the way the stroke management has progressed in the world. But I think in India, it is the last 1 decade where there has been strides which have been significant. And also because I think there have been stroke champions, like Shirish is a stroke champion. I mean, Arvind is a stroke champion. I know that, in each part of the world, you had the stroke champions who've taken up a challenge to make that difference for the stroke care. And I think the last part, which is my pet project, would also have to develop those partnerships of public-private, because the systems of care cannot just be public, cannot just be a private. You can't. You need to find those dialogues. You need to find those networks which are economically viable for everybody to survive and grow. And hence that systems will then go down to the deepest parts of the society and reach the poorest of the poor. And I'm telling Dr. Ratna again, we have to get this system into Ayushman package 3. And that should be after you do all this exercise, please, you will have to drive that before Ayushman package 3 comes, neurology figures. and the stroke treatment figures make it accessible and available to the poorest of this country. That should be the goal of this story of the journey of stroke. So I will end here, Shirish. Otherwise, I'll keep on talking and you'll kick me out. But that's been there and I'm passionate about it. And in whatever way you will want me to help or empower this in any way that I can think about, I will be there. Thank you all. Bless you. Thank you so much.
Thank you, Padma, for that extremely passionate talk. I know, I've known you for so many years. You're extremely passionate and extremely committed to stroke. And I think when you see a stroke, probably your emotions fire in. And I can see that right now. So thank you for that extremely passionate talk. And I think we will have a panel discussion where, your ideas, we would incorporate into some sort of an understanding between the panel. So I would definitely invite you to, wait for the panel discussion, because we would want your ideas, because your ideas mean a lot to us. So thank you for being with us. So I move over to Dr. Arvind Sharma. Dr. Arvind Sharma is the head of Department Neurology and Stroke Specialist at the Zydus Hospital, Ahmedabad. I've known Arvind for a number of years now. He's passionately interested in neurosonology, TCD studies of the brain, and has done a lot of work in this. And he is from the Calgary group in Canada. So this is an extremely passionate group of neurologists who come from Calgary and have settled in India. So I think Arvind is a great guy to have here with us. And I think he loves neurosonology. I've seen him in a lot of sonology workshops, looking for the bubbles in the brain and telling us what are the mechanisms of stroke. So extremely passionate person, Arvind. He is the secretary of the Indian Stroke Association. Padma had been a past president, and he is the secretary of the Indian Stroke Association. So Arvind, I think your talk is interesting, very interesting. Can digital change the narrative for stroke treatment? Please go ahead, Arvind.
Thank you. Thank you very much for the kind introduction, Dr. Shirish Hastak. I would like to thank Dr. Ratna for making this possible, and I thank from Indian Stroke Association, from the Indian Stroke Association side, that we have associated with this Stroke Alliance for the patient group, and it is really a wonderful initiative. And I would like to also thank my past president and Dr. Padma Srivastava and Dr. Shirish Hastak. Both were the past president for Indian Stroke Association, who has lit the lamp and took the Indian Stroke Association at this level. And we are always inspired by the passion, by what Dr. Padma has just told. My talk has already been delivered in that whole journey of stroke, what she has said in the digital one, because what the COVID has done to us, and we have to get digitalized for every aspect, that has already been done in the pre-COVID era, which Dr. Padma has discussed with you, right? It is the innovation, it is the thought process that you have to be in for the telemedicine or digitalization of the neurology or any branch. So I will just show you some slides, and that project is wonderfully done for the Himachal Pradesh. That is one of the best example which can be followed across India for a telestroke. Can I have my slides, please? Yeah, first slide. And you have to go one slide back. You have to go one slide back. Next slide, please. Next slide. Next slide. You're missing one slide. No worries. It's okay. Because that was the main slide which I want to show. Can you go back? Go back. There is one more slide there. Go back. Next slide. I'm sorry why it's not showing. That was the end game or the game changer slide. Basically, that's what I mean to say, which you are not able to see on the screen. Can we go to the next slide? I think it is not possible to show that slide. Next slide, please. So future of telemedicine, which is very important, the utility of telemedicine, which is very important in this aspect of the journey for telestroke, and specifically during the time of the COVID. the easy access to the remote areas where the lockdown was there and the people were not able to travel to the cities, as Dr. Padma very well said about the primary, secondary, and the tertiary care of the stroke, right, and the care system. So the people from the primary care, the village, they are not able, because of the lockdown, they were not able to reach to the hospital. And as we have seen in Himachal, we were using it as a telestroke. Across India, people were using WhatsApp and a different modality. And there are few centers which I'll discuss who are delivering telemedicine very well through the organization. So it is easy to assess the remote area where you can make your physician, the stroke physician, capable enough to thrombolize the patient or treat the patient in the acute clinical setting. So use telemedicine in the peripheral health setup for treating the stroke, monitoring home care and ambulatory monitoring. The another thing which happened wonderful, and that is a future, what I can say, that is not a digitalization, but to reach to the patient for a stroke, right? And that is what is known as the mobile unit or the mobile telestroke unit, where you have the CT scan, where you have the facility in the ambulance and can be reached to the doorstep of the patient, and you can do the acute treatment for those patients. That is another step forward during this COVID era. I will say pre-COVID, COVID, or post-COVID. So it improves the communication between the health providers separated by the distance, continuing medical education and clinical research, and many other things can be done by the telemedicine and treat the stroke. The next slide will tell you what Dr. Padma has told. Can I have the next slide, please? So that is about the gadget, and it was being made legal. That was the more limitation about the legalization of treating the patient from the distance. And that was on 25th March 2020. It was made legal to treat the patient with the telemedicine. So that helps a lot in treating the patient with the stroke. So can I have the next slide, please? So if you see in India, these are the programs which are supported by Department of Information Technology, DIT, ISRO, NEC Telemedicine Program of Northeastern State, Apollo, Asian Heart Foundation, state government, telemedicine technology, and little bit of part public and private partnership is being done at the many civil hospitals, as Dr. Padma has very rightly said, that because of the effort at the central level, and once the thrombolytic drug was at the shelf and free for the poor patient, even at the AIMS, and that was happened in the Gujarat state, where I work as an honorary associate professor. We have the drug and we can give to the poor, and we have the telemedicine support to treat the patient at the certain level of the periphery, where we can treat the stroke at the district level. So that is what we do even at the private hospital. We have a 70-kilometer radius where you can drip and ship the patient. By doing a telestroke, we can give a thrombolytic drug and patient doesn't improve. Having a major occlusion can be shifted for the treatment to the main center. So that is what the future is. You cannot treat every patient sitting at one center. If India is a huge country and with a lot of differences of the treatment line, only sprinkle of the tertiary and the quaternary centers available in the major cities, but everyone deserves the acute treatment. That is the most important part. It is PSC, CSC, or it is a tertiary care. Everyone deserves the acute treatment. Is it diarrhea or is it polio? Whatever it is, patient deserves the treatment. So that is how you have to think. If you have a 3,000 neurologists, what Dr. Padma was talking, and if you see the interest in stroke, maybe of 1,000 or 800, because we are more than 900 members for Indian Stroke Association. People have different interest in epilepsy, movement disorder. So how you think a 900 or 1,000 stroke neurologists will travel across India to treat stroke? So you need help, you need team effort at the district level, where you can train people and develop some courses and treat the patient with acute stroke by telestroke. So that is what it is. Future is telestroke. We can develop a tele-rehab, tele-prevention, tele-community, tele-search. So if you see, it is telestroke is like this, where in the real time, there is a no distance limitation, where you can see the CT scan and you can ask the physician, and the availability of the resources, the drug, the treatment, the people there to treat it. If they are all available, then it is not difficult for a stroke neurologist to treat a patient at a distance anywhere in India. So that can be taken as a chain to take a responsibility of a particular state for treating such. So telestroke is a next big thing which we have seen during the COVID time, but it was present in pro-COVID era, which Dr. Padma mentioned very well. And that project gave us all strength when we are treating telestroke. We are using a very simple procedure of WhatsApp sometimes, but definitely the University of Alberta, where I've done my fellowship, has shown that if you have a 16-slice CT scan on the mobile, you can easily judge that you can give the acute treatment to the patient or not. Because for us, CT scan is equivalent to ECG, and cardiologists are doing it. They are seeing the ECG remotely, and they are treating the patient with the physician in the periphery. Even with the general physician, they are treating the MI by seeing the ECG. Similarly, for us, ECG is CT scan for treating the stroke, because we want to know which type of stroke it is it ischemic or hemorrhagic? So that is how we treat the patient. Next slide, please. So next slide, please. So this was, I was talking about the stroke hub and how the telestroke can be driven by a comprehensive stroke center and the peripheral center. Next slide, please. So this is what I was talking about, the integrated structure, and definitely if it is done by the system, it will help a lot, but it is cannot be done alone by the Indian Stroke Association or the neurologist alone. It needs a comprehensive effort, like at the district level. Dr. Gopal, as Dr. Padma talking about Dr. Gopal, I heard him in the last stroke summit also, and those integrated approach are very well needed to treat the acute stroke patient. Next slide, please. So next slide. So I will just mention you about one of the telemedicine, the telestroke treatment, where it is seen that in person and the patient who are treated on telephone by a specialist doesn't make a difference. And the results are very good if you see the trial in this Tempest trial. Next slide, please. And there was a good amount of MRS less than 3 even treated with the telestroke. MRS less than 3 means if you have a less than 2 MRS, it means modified ranking scale that you have a very slight disability, and we want our patient to be from 0 to 2 MRS. 5 is severely disabled and 6 is death. So we want all our patient to be less than 2 MRS, and definitely it is seen on the telestroke. It has made a difference. Next slide, please. So I will end my talk. You can see the difference in this Tempest trial. Next slide, please. With the shortage of time, I think I should finish my talk by saying that, next slide, that telemedicine is safe, telestroke is safe and reliable. You can treat the patient when you make the other person capable to treat those acute stroke patient. You have to begin the preceptorship programs to make the aware physician about treating the stroke, because the most feared complication still in physician about the stroke is that they will develop hemorrhage with the thrombolytic drug. As there are a number of thrombolytic drugs available, 2 drugs are available, there is a lot of chances that the treatment can be delivered at the PSC and the CSC level. When it is done in India, then only we will be greater than 1% of the thrombolysis across India. We are still, what I know of, correct me if I'm wrong, Dr. Padma and Dr. Shirish, that we have not even reached more than 1% of the thrombolysis across India, what the population and the number of stroke is happening in India. So next slide, please. So it's a game changer, no doubt. Every modality has its limitations. The person touch is most important, but acute stroke needs treatment. So if it is done in any form, it is a good treatment. And definitely it cannot replace the in-person treatment for any specialist. Next slide. Next slide. Thank you very much for the patient listening.
Thank you, Arvind. I hope you can hear me.
Yeah, we can.
Yeah. Okay. Thank you, Arvind. I think, yes, a great idea, which I think needs to be, it's an innovative idea, which we need to utilize and move ahead. As someone said, once, that the future has arrived, but it is not uniformly distributed.
So I think, your telemedicine may allow a little bit better distribution of the future. So it's a great idea. Good, you've become you're an innovative person with Padma to move this ahead. So thank you for an excellent talk. And we'll have you in the panel so that, we can ask you some questions and discuss the telemedicine idea a little further. So we move on with the next speaker, the third speaker, Dr. S. Sundar, consultant physiatrist and founder managing trustee, Freedom Trust Chennai. And he's written a textbook on rehabilitation medicine. And of course, his talk is very interesting. His topic is also interesting, very interesting. Innovative models for stroke care in India. So I think innovation is something that, you see the same thing, but you think differently. So I think, hopefully we'll get something new, and I'm sure we'll get something new from Dr. Sundar in terms of how we would innovate and plan rehab further. So Dr. Sundar, please go ahead.
Thank you, Dr. Sirish, and thank you, Ratna, and Stroke Alliance for including the concept of rehabilitation into this panel discussion. Can I have the first slide, please? My topic is innovative models in stroke rehab, and since I am a specialist in physical medicine and rehabilitation, I assume that I will be talking only on innovative models in rehab care. And we do see a lot of patients, next slide, with residual stroke. And no two patients are the same. It needs a whole lot of rehab professionals like speech therapists, not just physiotherapists, speech therapists, occupational therapists, sometimes even an architect to plan a rehab program for a patient, which has to be systematic and customized. And only if the team is available can it be holistic. Of course, the earlier we start, obviously the results are much better. And of course, as I said earlier, no two patients are the same because the extent of the injury varies from person to person. And we need, of course, the patient and his family's cooperation and motivation to get him back. Obviously, whichever member of the team of rehab is available, like a physical medicine specialist or a physiotherapist, all are involved. Their skill is needed for the rehabilitation. Next slide, please. So when the patient comes, it's always what you ask him what is his problem. He says, I'm not able to comb my hair. I'm not able to write. I'm not able to wear my dress. It's always related to their day-to-day activity, which we call as ADL, or activities of daily living. So though it's everybody's interest to get back as to their pre-stroke condition, from the concept of rehab, it's our endeavor to see that as many of the abilities that were lost should be regained as much as possible. And the second most important thing is, if neglected, the patient goes in for contractures or subluxation of the shoulder and such other complications, which also include those related to prolonged immobility like DVT and so on. So in order to improve the patient's quality of life, we need to look at what he or she can or cannot do. And it starts with even with the dominance. Like a right-handed dominant patient is so much different from the management of a patient with the left-handed dominance, again, depending on which side is involved. And we don't stop short with medical rehabilitation because the socio-vocational aspect, can he or she get back to his work? Is he integrated into his family or just confined to one part of his house? Does he have a leisure activity? Is he depressed? Can he do his day-to-day self-care activities? All these are very important. So I shall now move on to what's new in our innovative models. Next. So the thing is, this entire team works together in tandem for the rehabilitation. Next. One of the good models of rehab care is an inpatient or step-down care model. Of course, this to reach even the rural parts, as spoken by my esteemed colleagues earlier, is a big challenge. But at least in cities, an inpatient rehab center would be of great help for those suffering from those related, surrounding areas, like body-supported treadmill training, where the patient is supported on a harness and the therapists work with them. Next. The same concept, by functional electrical stimulation, we can train them. Of course, a multi-channel is used mostly for paraplegia. Next. Of course, many patients may not even be able to sit down. So we need to train their writing reactions, their tilt reactions, sometimes clinically with the skill of the therapist, or using a balance trainer that you can see on the right. Next. And now we move on to what is very exciting, is this neuroplasticity. I'm not going into the details of what it actually is, but for those who are on this audience, it's enough to know that the brain is agile enough. Some of the cells of the brain have the ability to change the structure, function, and chemical profile, and reorganize and remodel after this injury. A lot needs to be done in the research of this, and a lot of papers are being presented on this. How do we use neuroplasticity? Next. So we use things like robots to train the activities of the hand. Next, the virtual reality. These are all new models coming up where you look at a monitor and do your activities. Next. Or constraint induced movement therapy, where you actually restrict the normal hand and make the patient use the affected hand for ADLs. Next. Or use music and rhythm to retrain gait. Next. Use of mirror therapy to fire the neurons on the affected side by looking at the normal hand and its reflection in the mirror. Next. This is also a very exciting thing. Biofeedback has been around for the last couple of decades, but this is a portable system that can even be taken to the patient's house by the physiotherapist to train the muscle, either to fire, to increase the activity, or even to reduce spasticity, to relax the muscle. So the patient next looks at a graph and tries to reduce, if you need to reduce the spasticity, looks at this graph. Next. And biofeedback has a lot of applications in muscle re-education and reducing the spasticity and enhancing relaxation in stroke. Next. Other forms of therapy are there. The imagination, the boundaries of imagination are needed: drama, creation, musical therapy, dance therapy, and so on. Next. When we cannot change the patient, look at the barriers. The barriers at home for ADLs, like if you cannot open the tap, change the tap. So these are the door handles and switches at home, or use of public transport outside. The public changes that's why we need an architect to design the house, the public buildings for accessibility. Next. More for the patient, self-help aids, reachers, built up thing. But usually the patient, if the other side is normal, they tend to transfer the skill to the opposite side. Next. For patients who are very sedentary, are not able to move around, environment control systems, using an environment control device. Next. So we should not neglect a lot of speech. A lot of patients have speech problems, so we should not neglect augmentative communication when they cannot speak. Next. So the take-home message: rehab should be started at the earliest once the medical stability is reached, and should be continued longer in order to prevent secondary disability like subluxation, contractures, and so on. Unless the patient is too ill or poor in cognition, no patient should be excluded from rehab. Some attempts from our side are being done for tele-rehab also. In general, rehabilitation-induced recovery seems to be greater and more effective than spontaneous recovery. Thank you. Next slide. Thank you very much.
Yes, I hope I'm unmuted. Yeah. Yeah, thank you. Thank you, Dr. Sundar. I think we will have you for the panel to tell us, how we could sort of bridge.
Of course, of course.
We will have you for the panel to, bridge this gap with rehab and patients,
Sure.
How do we bridge this gap is an important issue. I think I'm trying to bridge the gap between my video and me, hopefully I'll be able to do it. But I think as you can hear me pretty well, you may not be able to see me. You have to, of course, believe that I am there, unfortunately. But I will go ahead because the speakers are well seen. And so the fourth speaker is Dr. Bipin Gopal. So Dr. Bipin Gopal is he's the Assistant Director, Directorate of Health Services, Tiruvananthapuram. He is the State Nodal Officer for NCDs. And so he would have some unique experience in this field. And so I think we look forward to his talk. The government of Kerala has given him the best doctor in the modern medicine award for 2015. So we look forward to his talk, which would throw some new light into how we bridge the gap between the doctor and patient. So please go ahead, Dr. Bipin Gopal.
Thank you, Dr. Sirish. Am I audible? Am I audible?
Yes, you are audible. You're audible. Yeah, please go ahead.
Okay. So at the outset, let me thank the Dakshyam and the Stroke Surveyor Foundation for giving me a chance to speak in this very good platform on World Stroke Day. Good afternoon to the distinguished panelists. Can I have my slides? Second one. Okay, Kerala is a small state at the southern end of Kerala with a population of 33.39 million, with a high population density of 859, with a high literacy of 93, and a low MMR of 0.08, and a low IMR of 8 and low MMR of 42, with a high life expectancy of 75.4. This picture may seem very rosy, but on the NCD side, at the non-communicable disease side, we have a very bad picture. We have a high percentage of hypertension, that is 40% among the males and females in Kerala. We have a high diabetic load of 27%. We have a high obesity load of 32% among the women, and almost 32% of the total death is due to the cardiovascular diseases. So this is the, Kerala is on the highest epidemiological transition zone, and we have shifted from the communicable diseases and the RCH issues to the non-communicable disease side. That is the scenario in Kerala. Next slide. So when you look at the stroke also, we have a total stroke of nearly 135 per 1 lakh population. It is almost same in the urban area and rural area, since the urban-rural divide in Kerala is very thin. And out of that, ischemic stroke presents 74.8, and the intracerebral bleed is 10.1%. But the stroke-ready institutions in the government sector is quite few. If you look at the map, you can see that there is one Sri Chitra Tirunal Institute of Medical Sciences in Thiruvananthapuram district, and there is one medical college at Thiruvananthapuram district, but none of the other districts had a stroke-ready facility available in the government facility. This was a picture in 2014. So that made us to think about a stroke policy. Next slide. So it was a rollout of the stroke program in the state in 2014. So the initial thing that we did was to train our physicians at Sri Chitra Tirunal Institute of Medical Science and Technology. Since we don't have much neuro physicians in the government sector, we had to train our general physicians for stroke management under the Sri Chitra Tirunal Institute of Medical Science and Technology. There was training of staff nurses, there was training of physiotherapists, and the Boringa Ringelham company, with the help of angels, they also supported in training the physicians, the emergency care medical officers, and the staff nurses on NIHS scoring, then emergency transportation of the patients. So all these trainings were done initially. And we, from the state, we gave 30 lakhs each to every district hospital for setting up a stroke ICU. And the equipment list was as per the national guidelines, and that equipment list as per the guidelines were procured, and a stroke unit, a dedicated stroke unit was set up in almost the majority of the district hospitals in the state. And the biggest challenge was procurement of TPA. Since TPA was a costly drug, and since TPA was not in the EDL list, in the essential drug list in 2014, we had a difficulty in getting that sanctions from the government, but somehow using the NPCDCS funds and the state funds, we procured the TPA and we made it readily available at all the stroke units. Next slide. And it was a structured stroke management program. And right from the top, the government that declared stroke management units as its flagship program in the governor's address. So we made that a mandatory thing at the district level hospitals, and there was a political commitment with the governor's address. And we did not choose the districts, we made all the districts available for the stroke care facility. And Dr. Shailaja from the Srijitra Tirunal Institute of Medical Sciences, she was designated as the state technical consultant for stroke management. And the standard operational guidelines for stroke management was also issued. Funds were made available from the state plan fund and from the NHM. And teleradiology facility, with the help of HLL, the Hindustan Latex Limited, was there in all the district hospitals. We had a pact with the Hindustan Latex Limited. We have CT scans in all the district hospitals, but the availability of the radiologist was a big problem. So any patient who is coming in the odd hours or in the off hours, their pictures will be taken and the pictures will be uploaded through the telemedicine network, teleradiology network by the HLL, and we will get the results within 20 minutes time. So that is the mode of agreement that we did have with the Hindustan Latex Limited. Next slide. And in 2014, we launched the program called Shiras. Shiras in Malayalam means head, but there is another meaning: stroke identification, rehabilitation, awareness, and stabilization program. And our Honorable Minister inaugurated the program in 2015. Next slide. And for every program, there are some key players. So we should thank them, the visionaries who made this program a huge success. It was none other than our then Principal Secretary, the Additional Chief Secretary, Mr. Rajiv Sadanandan IAS, who actually pioneered this program, who was a visionary, who actually mentored this program and made this possible at this level. And the next person whom I need to thank is none other than the Padma Shri winner, Dr. Padma Srivastava. Madam, we are so obliged to you because there were a lot of resistance, lot of hesitations among the physicians and the specialists regarding the decentralization of stroke management program in Kerala. But it was your presence in Trivandrum, it was your speech, your passionate speech in Trivandrum that changed the attitude of many people, and which actually laid the road open, the gates open for this program. And the next person whom I should thank is Dr. Shailaja, who is the current head of Department of Neurology in Kerala. She is spearheading the program in Kerala right now, who's supporting in the training program, in renewing of the program. And the other person is Dr. Vivek Nambiar, who was the neurologist in Amrita Institute of Medical Sciences. Even with our training, even with our hand-holding, the doctors were reluctant to start the thrombolysis. Next slide. It was Dr. Vivek Nambiar who brought in the Telestroke idea. Dr. Vivek was in the Amrita Institute of Medical Sciences. So a physician sitting in the district hospital will send the CT images through the telemedicine unit to Amrita Institute of Medical Sciences, where the hello. where the report and whether to thrombolize or not, that opinion will be given by Dr. Vivek Nambiar or some other person sitting in the Apex Hospital in Amrita Center. So we started this program in 2015 itself. Next slide. So this was the first patient who received the thrombolysis therapy at District Hospital, Ernakulam. It was given by a physician in Dr. Manoj. It was not a neurologist who gave the thrombolysis therapy. And that news, and the patient who came with the grade 3 paralysis, he was totally normal and he was walking back home. And the news came in the newspapers, and it was the district collector of Ernakulam who came to the hospital, our general hospital Ernakulam, to discharge the patient. So that was the enthusiasm among the bureaucrats and the policy makers. Next slide. So after the Shiraz program, when there was only 2 stroke-ready hospitals in Trivandrum in 2014, now in 2021, we have 10 stroke-ready hospitals spanning across the state. 3 more are going to come up this month, and 1 will be coming in 2022. So all these hospitals have a dedicated stroke unit, and all these hospitals are equipped with tissue plasminogen activator, and their trainings, their modules, everything is ready. They are all stroke ready. And we have successfully given 146 thrombolysis so far. Next slide. So this is one of the stroke ICU that we do have in Trivandrum General Hospital, and almost all ICUs are the state-of-the-art ICUs in the state. Next slide. So out of the 108 cases, even though we have done 146, we did an analysis of 108 cases, and 90 to 100% of the patients came within the 4.5 hours time. Since it is in the district hospitals, they had an ease to come to the district hospitals, and so we could give the drug in the 4.5 hours window period, and there was 90 to 100% recovery in 62% of the patients, and it was 80 to 90% recovery in 28% of the patients, and less than 80% for 11% of patients, and only 7 failures were recorded in our history when we thrombolyzed 108 patients. So this is a huge achievement as far as the state is concerned. Next slide. And this is a community level intervention, which we started with the help of Sri Chitra Tirunal Institute of Medical Science and the Health Services Department. Again, Dr. Shailaja was in the forefront. It was an intervention study. It was a study as well as an intervention which covered the rural areas of the Trivandrum district. The idea was to find out the stroke survivors. So we trained our medical officers, we trained our field staff, we trained our ASHA volunteers in identifying stroke. So if a patient has got a symptom of stroke or some neurological symptoms, the initial suspicion of stroke should come in the first place. So we trained and retrained our medical officers, we sensitized our field staff, we sensitized the ASHA workers, because they are the people who are working close to the community. So any patient who is developing some symptoms, the fast symptoms in the community, the ASHA volunteer will take them immediately to the medical officer. And the medical officer in the PHC will examine the patient, will stabilize the patient. And once he has the suspicion of stroke, he will be transferred. The patient will be transferred to the medical college or the district hospital in the nearest ambulance available. So that is the mode of intervention that we did in Trivandrum. And we also found out the stroke survivors, because many of the stroke survivors, they were not showing any complaints to the treatment after the recovery. So they were discontinuing their medicines. They were not doing the physiotherapy. So one-to-one, the patients were identified by the ASHA workers and the health workers. They promoted them to have the medicines. They promoted them to have the physiotherapy, and we could reduce the incidence of repeat stroke and after stroke. And we made that a study, and the study report is published in the Journal of Neuroscience 2 months back. And this year, the same intervention, we are going to cover we are going to cover the Kollam district. So we are slowly planning to have this intervention done in all the districts of Trivandrum, in all the districts of Kerala. Next slide. And further reaching out to the people, we developed modules on stroke management for the health workers and physiotherapists in Malayalam language, so that the health workers can read, they can practice themselves. And for the physiotherapists, we may also made a physiotherapy video so that they can study physiotherapy for the stroke victims on their own. The stroke rehabilitation units were set up in all the district hospitals. Like the previous speaker said, we have the most modern stroke rehabilitation equipments in all the district hospitals, and it is under the charge of a physiatrist and with a trained physiotherapist. And further moving down, in all the community health centers, we have one physiotherapist posted exclusively for stroke rehabilitation. So they were also given training. A mini physiotherapy unit was set up in all the 227 community health centers across Kerala. So the patients may be finding it difficult to come to the medical college or the district hospital for physiotherapy. So, but it is for them, it is easy to come to the CHC, or the physiotherapist can go to their home for domiciliary service. So this is one intervention that we have done for decentralizing the stroke care. And palliative care is one of the robust moving program in Kerala, and all panchayats are having active palliative care services, and majority of the almost 60 to 70% of our palliative care victims are stroke victims. So we are covering the stroke management at the district level, at the PHC level, at the community center level, and at the community level. So that is it from my next slide. Thank you. Thank you very much for patiently listening.
Excellent talk, Dr. Bipin Gopal. I think we should give him a, give him a hand, because, I think he deserves to be, congratulated for an excellent talk. I take back my statement, Dr. Bipin Gopal. The future has arrived and it is uniformly distributed in Kerala.
Yeah. Yes,
so
sir.
I think it's fantastic. I mean, otherwise, for the rest of India, it's definitely not uniformly distributed. Maybe Padma has helped Himachal Pradesh, but you have helped Kerala. Fantastic. I think, you deserve accolades and, hats off to your work. So I think excellent work, and you have transformed Kerala. So I think it's just the ability to push on and move ahead and do what has not been done before. So I think we congratulate you, and I think your innovative ideas can be translated into other states, and you can be a leader in translating ideas to the other states. So I think I look forward to you as a leader in terms of translation of ideas into other states. I think so accolades and hats off to you, Dr. Bipin Gopal. So I think you will be there in the panel. So we would want your ideas, to how other states should move, and how Maharashtra should move as well, and how we should try and move the other states. Now, so we will move to the last speaker, Mr. Jitendra Vashni. He is a consultant, IBM Private Limited. He's an M.Tech from IIT and is a software consultant. So, as neurologists, we are also software consultants, but our software is up here. His software is down there. So yes, but it'd be nice to listen to him. Sorry, can I have the
And good evening, everyone.
Yeah, hi. And his talk will be interesting as he's a stroke survivor, and he has suffered an ischemic stroke in 2018. And we look forward to his ideas of how we could help patients. Go ahead, Jitendra.
Yes, good evening, everyone. Good evening to all my fellow panelists and Ratna ma'am and all Dakshma who are arranging this forum. And actually, we have already crossed our time, but I will not take much time. I will just raise few points because I am a voice of all the survivors. So it's my duty to put some points. So if we talked about the first thing first, the education or the awareness. So as in India, we know India is not so good in the awareness of the stroke.
rehabilitation. Doctor already covered this topic. So when patient discharge from the hospital, their family or patient should be educated enough about their next life, because after post-stroke the life is entirely different. So that's where we are lacking in our place in India, basically. So we should have a good forum to provide the guidance to the families and the stroke survivor also, and do's and don'ts basically. And we should have a good rehab facility. Good in the sense we should have advanced technology like robotics and all. We do have in India, but that are very costly. We should have economic. It should be sponsored from the government. If my voice can be reached to government, they can take some initiative to set up some economic rehab facility in India with the advanced technology, modern equipment. And the next thing is the survival benefit. So whenever if somebody is the only earning member of the family having the stroke, may lose their job. That time somebody like government or some NGOs may come and give at least a job to any of the family members for their survivals as per their skills. And the last means there should be a strict action on the hospitals which are doing the medical negligence, because there are a lot of people like me who are the victim of the medical negligence, and because of that we are suffering. So if my voice can be reached to the government officials or our policy makers. And one more thing, we are not covering stroke rehabilitation in our medical insurance. That should also be covered. I mean, there is a major point which I forgot to take at the first. Yes, sir, from my side. Thank you, everyone.
Thank you, Jitendra. Thank you for that talk, and thank you for telling us, the points the gaps that are in the system. And thank you for telling us that very important point that your insurance doesn't cover, your problem. I think let's go on with the panel. So can we go one at a time, Arvind? Yeah, I think.
Ask Manish to mute the mic of
Yeah, I think someone's. Yeah, can we have Padma? Yeah, Padma, are you there, Dr. Padma? Okay. Otherwise, we will have Arvind then. Arvind, what do you think we should do? I had noted some points, but you can, your ideas. What do you think?
Definitely. Thank you, Dr. Shirish. What a discussion as a panel, which we have done as a journey of stroke care, about the digitalization, about the district level, as a physiatrist, the rehabilitation part, the sentence which you have said, not only physiotherapy, was very important for me, right? Which we all understand that it is not moving the limbs up and down as physiotherapy, right? It is a goal directed. So I really love the panel, the discussion went, right? And listening to the stroke survivor, which is always very important feedback which he has given for the government, and the acute treatment is very important. So overall, if we take this whole panel discussion which we did, there are a lot of things need to be integrated. Like as Dr. Padma said, when I worked I did my fellowship, as you told, in Calgary. We saw OTPT work together as a stroke fellow, right? And you also did that. And people work together to make the decision, not as a one person to make the decision about the patient. So stroke is like this. You cannot, we see patient after 3 months of their acute treatment that they should be independent in doing their activity. That should be the motive. How it can be done and who can do it, it is an integrated approach. There is a leader agreed as a stroke neurologist, but they walk together. They don't walk, one is walking ahead. That is not the case. And that is what Dr. Gopal also mentioned when they start teaching at the physician level, right, and start developing that integrated network, that things happen. People should not think that what to do now, right? Where to go now? If the acute stroke happened, we are going to the hospital, but now for the physical rehabilitation, where to go now? That is how the irrational medical therapies and physical therapies develop, and a lot of people suffer because of it. So there should be some uniformity in the program, which I think as an advocacy Stroke Alliance should do. And Dr. Ratna, as Dr. Padma has said that about the Ayushman Package 3, I agree with her that every sector is important, right? And if we can reach to the level we want is that everyone deserves the treatment. It is not at the tertiary care only in Ahmedabad, Delhi, or Thiruvananthapuram or Chennai. Everyone deserves stroke treatment, and that can only be done if the Stroke Alliance like groups do the advocacy for the stroke management. Thank you. Dr. Shirish, you are mute, I think. Yeah, you are mute.
Yeah. Thank you, Arvind, for your points. And I think we have taken down some of your points. We will, pass them on. And thank you for your contribution to the discussion. I think we move to Dr. Sundar. Dr. Sundar, would you like to make a few comments as a panel person? Yeah.
Thank you, Dr. Shirish. The first thing I would like to share with you is that after so many years, rehabilitation is now a part of the MBBS basic curriculum. Now that is a step in the right direction, because a lot of medical students at the undergraduate level will get to know the various approaches to managing people with residual disability. I, as a student, never got to know much about rehab during my undergraduate days. So that's the first thing. Second thing is what we are talking about. My topic was innovative models, but all what I said is available only in a select few hospitals and centers in big hubs, But I have traveled the length and breadth of the country. I am also a President's Award. I have received the President's Award for Social Service, and I do know, and through my trust, I have traveled, and I do know that the picture of persons with disability, not just stroke, but all disability, the picture is so different in rural India as compared to the urban. And the last thing is, or the third thing is, a very relevant point is insurance. Insurance does not cover rehab. And that is a major deterrent for many patients to approach rehab. One thing is they are already unable to move around. And if they have to pay so much for their rehabilitation, I think people who can afford insurance should also be covered under rehabilitation. And the last, and I think a very important thing, which is available in many places abroad, is accessibility. And public places and even homes designed for persons with stroke, post-stroke residual disability, needs to be emphasized at all levels. Also the government, but also at individual architects and so on. Physiotherapists and physiatrists and other rehab professionals, it's good to include them in this Stroke Alliance, to get to include them and include their opinions in management of post-stroke residual disability. Thank you.
Thank you, Dr. Sundar. I think we've taken down your points, and I think a very, very valid points for creating awareness and creating a sort of a gap, bridging the gap between the patient and the doctor. So I think thank you. We move on to Dr. Bipin Gopal. I think Dr. Bipin Gopal, your model should be called the Kerala model of innovation. And I think, the key problem I face is that, one and one are two, but the problem is with the and, isn't it?
Yes.
It's easily said that one and one are two, but, when there are two people, that and you have bridged very well. So I think you should be the Kerala model of innovation in stroke. How did you do it? I mean, is the question I want to ask you. How did you bridge this gap?
Sir, when we have a person like Mr. Rajiv Sadanandan as the additional chief secretary, that bureaucratic support was the biggest boon for Kerala at that time. And there was a strong political will also. The ministry was also in favor of that. So we, if we start from the top, definitely the bottom line will, they will agree to that. And there were some resistances initially, and they were sorted out with the help of Dr. Padma Srivastava, Dr. Shailaja, some other neurologists. So issues will be there, but if you have a political and a thorough will, definitely things will happen. And when we plan things, what I feel is that you should plan it at a decentralized level. How the people can get access to that. I will start from where Dr. Sundar has stopped. Accessibility to the services is the most important thing. If we develop a super specialty center at the district headquarters or the state headquarters with all facilities, state-of-the-art facilities, that is not going to benefit much of the population, because majority of the population are living in the grassroots level. So the services should be rendered at their level. Then only people will come out. So we should strengthen our primary care system, our primary care doctors, our primary care physicians, and we should set up model stroke stabilization centers at the primary care level itself. Because if only that physician has that clinical suspicion of stroke coming to his mind, that patient will go to the new stroke facility in time. If that suspicion is not there, he will go back to this house thinking it is something else, and he will end up in stroke. So motivating the people from the ASHA to the health worker, to the medical officer, and to the bureaucracy, it is a passionate work to be done, but somebody has to take the reins and somebody has to make the show going. And one more thing which we are now trying to do is...
We are very happy that you have... I think it's a fantastic achievement, and I think we should invite you to come and meet our chief minister to try and transform other states as well, because your model has worked extremely well. And I think the proof of the pudding is that in eating it, and I think your model has worked extremely well. So I think you deserve the idea that innovation can work, and of course teams can work, and so I think we will invite you to further other states to also help other states have
definitely,
have more.
sir.
Yeah,
Definitely.
It would be a pleasure to meet you. I think we move on to the last speaker. Yeah, Arvind, you want to make a comment? Yeah, Dr. Arvind, and I think we move on to the last speaker, who was speaking from the patient point of view, Jitendra. So Jitendra's points, I think we have already taken down. Jitendra wants to make any comment to the panel if he's forgotten something, but otherwise, Dr. Ratna, we are a little out of time. And so we are sorry about that, but I think this session went off extremely well. I hope you have made the points. I have made some points. I will send them to you. We will definitely invite the whole panel again to interact. And of course, we will, as I said, use the Kerala model to move ahead. So I think, thank you for bringing Dr. Ratna, unique people with unique experiences and helping us move ahead. So I hand over to Dr. Ratna, and we will be in touch with you all. Dr. Ratna, please go ahead.
Thank you, sir. Thank you for that fantastic discussion that we have had. We had heard so much about the Kerala model that we managed to get Dr. Bipin out of hospital and attend the session today. And we are very, very grateful for that, because he had an injury and even then he consented to come and make a presentation. So thank you so much, Dr. Gopal. We do have 4 questions, but we are completely out of time. So I will send the questions to the panelists so that we can get the answers and put that in our report.
Sure.
Thank you so much. Thank you once again.
Thank you, everyone.
Thank you. Thank you.
Thank you very much. Thank you.
Thank you. And we now move on to the next session, which is by Dr. Pradeep Joshi. Dr. Pradeep Joshi is traveling. He is in Udaipur, which unfortunately today has an internet lockdown. So we have managed to have his recorded video and a brief introduction. He is the National Professional Officer, NCD of WHO Country Office for India with over 15 years experience. And he is providing technical assistance to various state governments for strengthening the national NCD program and has been engaged in frame of National Multi-Sectoral Action Plan for NCDs. Manish, can I have the video, please?
Namaste and good evening, everyone. I am Dr. Pradeep Joshi from WHO Country Office for India. And first of all, I would like to take this opportunity to thank Daksham Health and Education, the Indian Stroke Association, and the Stroke Support Alliance for organizing this much needed consultation on the eve of the World Stroke Day. Friends, I have been given responsibility to talk about patient voice in the policy based on the learning from the WHO Diabetes Compact. And I have structured my presentation in 3 sections. First talking about the association of diabetes and the stroke. The second about what is the WHO Global Diabetes Compact. And the last about how we can do the meaningful engagement of patients living with the diabetes. Friends, we are all aware that there are estimated 77 million people suffering from the diabetes. And to add further, there are 25 million people who are pre-diabetic, which will convert into the frank diabetic in the future. A worrisome problem is that more than 50% of these individuals are unaware of their diabetic status. It is well evident that diabetes is independent but a modifiable risk factor for stroke. And the risk of the stroke is 2 to 3 times higher in the patient who are suffering from the diabetes. And the risk goes further higher if the patient have comorbidities like obesity and hypertension. The good part is that having proper glycemic control and healthy lifestyle can reduce the incidence of the stroke among the diabetic patients. ICMR in 2017-18 conducted the survey on NCD risk factor survey, and based on that, it has been identified that around 49% of the urban population and 27.2% of the rural population are on the diabetic medication. And if we talk about the control rate, which determines the outcome of the diseases or the stroke or the incidence, is only 19% in urban area and 13.5% in the rural area, which indirectly denotes that either the patients are not taking drugs properly or they have issues related to accessibility or availability of the diabetic medication. If we talk about the availability of essential medicines at the primary healthcare level, the availability of metformin and insulin both in urban and rural area is around 21%. The availability of at least one glucometer or glucose strip or urine strips is around 52% to 47% in urban and rural public health facilities. About the health-seeking behavior, most of the patients are going or seeking treatment from the private sector, and even in the public sector, the allopathic practitioner consultation ranges around 22% in the urban area and 19% in the rural area. WHO has launched the Global Diabetes Compact, coinciding with the 100th anniversary of the discovery of the insulin, and recognizing that still majority of the patients don't have access to the insulin. And this was launched in the 2021 with a vision to reduce the risk of the diabetes, and those patients who are suffering from the diabetes have equitable, affordable, accessible and quality diabetic treatment and care. There are 8 areas in the Global Diabetes Compact, but I will be focusing primarily on the 5 which have a close relation with the patient living with the NCDs, with the diabetes. The first is about talking about collaboration and multi-stakeholder approach involving the patient living with the diabetes, also in defining the agenda for prevention control of diabetes. The second is taking steps for diabetes prevention and management and integrating into the primary healthcare as well as the universal healthcare agenda to reduce the financial hardship. The third one is about improving access to the treatment, especially about the diabetes diagnostics, medicines, and healthy products, especially the insulin one. The patient living with in the humanitarian emergencies also faces the hardship, so there is need to improve diabetic care and allocations of adequate resources and funds over there. The fifth one is improving understanding of the diabetes among patients living with the diabetes. And the other three components of the global diabetes component compact is talks about the innovation, about the setting up the targets for the diabetes, and the last one, building back better from the COVID-19 emergencies. Friends, before developing this WHO Global Diabetes Compact, there was an informal consultative process was done patient living with the diabetes, considering their importance in policy making process and their ability to convey their lived experience in the policy making and in the engagement process. The outcome of the consultation, where 140 participants from 37 countries have participated, was that meaningful engagement should act as a guiding principle for a high-level decision-making process. And there is a need for building an engagement framework to support the transition, the voice or the stories of the patients into the partnership, into the advocacy and implementation part. The outcome was also defined, that the patient living with the diabetes must be valued as experts and agents for the change, and there is a need to improve access to the education, social support, and the global price tag for having equity in the cost of insulin and other medication related to the diabetes. There should be proper representation in terms of diversity, ethnicity, gender, and intersectionality. Patient should not be considered as a virtue, and the policy should convert from patient-centered care to the people-centered care. And all this require comprehensive landscape review, what have been done in other countries to share with the other countries and conducting those research to further improve the meaningful engagement for the NCDs. Based on this consultative process, a document has been devised which is nothing for us without us and focuses on the domains for the meaningful engagement of the NCDs. In the one domain about the governance, we all know the UN high-level political declaration for NCDs have focused on bringing the patient living with the NCDs in the decision-making table and involving them for co-creating solutions and through the participatory approach, and also creating an enabling and protective environment for patient living with the NCDs. The collaboration and partnership is required to have improved access to the treatment and the opportunities because these are considered as barriers for the patient living with the NCDs, and bringing their successful models of engagement or developing the right tools and resources to influence the community and the group of people about the diabetes management and care. The patient living with the diabetes also have important role in the implementation of the program. The proper stakeholder mapping need to be done, and lessons learned from the other national program can further enhance their role in the implementation of the program. We all know about a huge gap about the understanding of the diabetes among patients living with diabetes. So that needs to be improved about how the prevention and the treatment can be done for the diabetes, and their need of a proper consultations to bring together the diverse voices so no one is left behind. Friends, we have to leverage on the existing policies and program environment, and Healthy India Alliance has come up with the India advocacy agenda of people living with the NCDs, which talk about how to meaningfully engage the patients living with the NCDs, and even the comprehensive primary health care through health and wellness centers of Ayushman Bharat speaks about the engagement of patient in the improving the care and the prevention part. There is also opportunity to learn from the other programs, especially HIV, tobacco. Tobacco, we know voices of the victims, how it has influenced the tobacco control program and the policy making process at the different level, whether it is governance at the government level, at the media level, at the judiciary level. There are other programs where there are practices of involving patients in the decision-making process like TB, malaria, and maternal child health. Friends, I will end my talk with a quote from my DG, Dr. Tedros, which says, WHO values the voices of patients living with diabetes, their expertise and inputs, and WHO is committed to leverage its role in supporting member states in doing the same. Thank you for patiently listening to me, and I'm happy to answer the queries. If the time doesn't allow, please reach out to the organizer and I will try to reply as much of your queries. Thank you and namaste.
Thank you, Dr. Joshi, for that lovely message. Nothing without us for us, or nothing about us without us. And that truly embodies the message where patients have to be involved in every aspect of the journey, whether it is a treatment, the rehabilitation, policy making, access to treatment, clinical trials, the entire spectrum. And that brings us to the next part of our panel, which is the second panel that will look at socioeconomic and psychological aspects of stroke, an area that is often neglected and not much talked about, especially because the health sector does not look at psychosocial rehabilitation. It's the Ministry of Social Justice that does. And usually these two ministries don't talk to each other. So bringing together the whole panel is the chair, Dr. Madhuri Bihari. She needs no introduction. She's an icon and a stalwart. Everybody in the neurology area knows her very well, but it is my honor to introduce her. She's the current director of neurology at Rajendhal Fortis Hospital, Basant Kunj. She's also the ex-professor and HOD AIMS, New Delhi, and a visiting professor at BP Koirala Institute of Health Sciences, Dharan, Nepal, and Massachusetts General Hospital, Boston. She has several honors, awards, recognitions. The list is very, very long. And she has over 370 peer-reviewed scientific papers, 30 book chapters, and she has written 6 books. She has several fellowships and memberships. That in itself tells us about the wealth of knowledge and experience that she will bring to the panel. Over to you, Madhuri, ma'am.
Thank you very much, Dr. Ratna, for these kind words. It is my privilege to be invited for this meeting for the lay people and the survivors of stroke. And as we know, that this meeting is certainly very different from the ones we have had earlier in the past on stroke. This is basically for the people of survivors of stroke and with the mind to look after them and what we can do in future. And this is not so much academic as most of the other meetings are. And in this, in which only doctors and neurologists used to take part. But in this, we have people from all walks of life who look after the patients of Parkinson's, including physiotherapists, physiatrists. And I think we should also need to have people who take care of speech therapy, language therapy, and psychologists and psychiatrists. All should be there involved in this because the patients, a person who gets a stroke once in one's lifetime has so many issues in his life, whether I'll be able to go back to my work, what will happen to my family, my children, how will they look after themselves? All those things are there, and that makes the person very anxious and depressed. So we have to look after that, all those aspects. So in this, I'm very happy and delighted that Dr. Ratna has taken care to include this part of the session also in this meeting. And I'm really obliged to Dr. Ratna, Dakshayam, and the Forum for Patients Stroke Support Alliance of India. With this, these words, I will want to invite all the members of the panel. And our first speaker is Professor Sunil Narayan, who's a senior professor in the Department of Neurology at Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry. He is also the founder program. He also runs several programs in education like DM Neurology, BSc and MSc in Technology, and also postdoctoral fellowship in stroke medicine, also PhD. He has several qualifications like DM, DNB, and others from UK like FRCP. He's also an FRCP also. His area of interest are stroke, autism, spectral EEG, neurobiology, and neurorehabilitation and modulation. He has several publications and total grant of more than 1.5 crores to undertake several research projects. He's organizing secretary of tropical neurology.
I'm very much here.
So can I now request Dr. Sunil Narayan to please take over and give his talk? Dr. Sunil Narayan, please.
Yeah, thank you very much, madam, for that very kind introduction. And I thank Dr. Ratna and the entire Health Alliance group for giving me this opportunity. I have once again encountered an issue with the getting my video on. I am clicking on it, but it's just refusing to start the video. So I don't know what exactly is the problem. So for the time being, I think I remain hidden, but that's not voluntary. There is an issue. I'm just clicking on the start video, but it's not switching me on. So if anyone can help me with this, I'll be grateful, but otherwise I don't want to waste time and I'll be happy to go ahead. Is that okay?
So you can join it again.
Do you want me to log out and try again?
Yes, sir.
All right. So do
Dr.
you want
Hari?
somebody else to fill that?
Yeah,
time
Dr.
slot?
Hari, you can take the next.
All right. Okay. Sorry about that.
And this is Dr. Dharam Pandey. He's a senior consultant and head of the Department of Physiotherapy Department and Rehabilitation Department at BCMSCT Manipal Hospital at Dwarka, Delhi. He is Associate Professor of Department of Physiotherapy, Institute of Applied Medicine and Research at Ghaziabad. He is also a consultant physiotherapist and rehabilitation at BLK Super Specialty Hospital, a research associate of Indian Journal of Physiotherapy and Occupational Therapy. He has several other awards, which will take a lot of time to complete this. And his significant contributions are AIMS Neuraxis in 2013, Clinical Excellence Award in 2015, and Best Clinician Award in 2018 at Jamia Millia Ismailia College, University. So Dr. Pandey, please, you are there.
Thank you, ma'am, for kind introduction. And thanks to Sports Alliance and Indian Stroke Association for organizing such a wonderful panel discussion. As Dr. Bihari ma'am said, that this is the unique topic we have. I would put my views on three headings. The earlier speaker also, I was listening to that, they were focusing on the awareness and other things like where we are lacking in stroke rehabilitation part and overall stroke care in India. So the first thing I would emphasize that about the awareness, that you all agree with me that the rural population, as we are talking about, my topic is the rural and urban gap is there in rehabilitation perspective of a stroke. So with context to that, you all agree with me that rural population is not even aware about the term stroke. Forget about stroke rehabilitation, post-stroke rehabilitation. So the community level rehabilitation, education, and in fact, overall stroke has to take place, and these population must be made aware of stroke prevention, treatment, and rehabilitation, and basically changing their mindset. That most of you must have heard that once the stroke is happened, and the people run here and there after discharge, even though they get a very good care in acute stroke and they are managed to survive, then after there's some kabutar ka khoon and then some jhaan phook and all that, they get lost actually where to go after acute care. So that's the very important point, that we should have an awareness programs, like earlier the speaker was talking about awareness program, and some Ayushman Bharat and all that programs has to be taken care and promoted at the community level. And the second things I would emphasize, that the cost of rehabilitation, the most of an advanced resources, particularly advanced technology which is related to rehabilitation, are very much limited to urban areas nowadays. And because it is so, because most of these technologies are very expensive to set up, and everywhere it can't be afforded to establish in a rural area or smaller centers. So why it is so? Because we need to import those equipments and those technology to India, so it becomes so costly, and everywhere it is not present. So there are very much limitation in that as well, that advanced rehabilitation facilities are lacking in our country. So I would suggest that the most of technologists in India, and they should move forward towards the Make in India program, and they should they start developing the cost-effective technologies related to stroke rehabilitation in India. So that could, in that way, we can take care of this problem. And the third important thing I would focus, and I would mention here on this platform, that and the policy maker and the government, and they should start thinking about developing and generating the workforce, rehabilitation workforce in India. We have a very limited competent workforce in related to rehabilitation in India. When I say competency, that means professionals. Yes, of course, we have physiotherapists, we have physiotherapists, speech therapists, and all that. But it is not that that they are well aware and they are very expert and competent in stroke, particularly in stroke. They might be in expert in neurology or neurosciences, but not in a particular stroke. The earlier speaker was a very eminent speaker, and he is specialized in stroke medicine. So why not we have something like stroke rehabilitation as well? So that has to be focused. And most of people think that it is not that once a stroke has happened that one side is paralyzed. Stroke is a lot more. It affects whole family. It affects the mental the well-being. It's and most of people in rural area. I was going through some of article that most of rural area patients are suffering from depression, post-stroke depression, but they are not even diagnosed for that, and even they are not aware about the clinician is not aware about that the person is going around with the post-stroke depression. So all these things need to be taken care. So we need to have focus on these particular area, like creating awareness about stroke prevention, treatment, and rehabilitation, particularly in rural area, which is very much lacking, and developing and make in India most cost-effective rehabilitation technology, which we can build up. There are a lot of good institute, IIT and other, they are working, but still we need to have focus to develop most advanced technology in India as well. We need not to import those, so it becomes so costly. And the third last is the workforce. We need to work on developing stroke rehabilitation and stroke medicine specific task workforce in India. So these are my few points, ma'am, that these we need to work on.
Thank you very much, Dr. Pandey. Now, I can again ask Dr. Sunil Narayan if he's ready with his talk. Can he just come in?
Yeah, I'm fine. I'm actually on the already here.
Okay. Yes.
Yeah, I think so. Thank you for patience, and I have sorted out. Thank Tamanna for giving me the opportunity to again rejoin. But I found out that I'll just start with giving you a all tip. I had switched on my webcam of my laptop to see whether everything is fine, and then I forgot to switch off the webcam. That's the only reason why it was not connecting. So please make sure that if you have a video problem, make sure your webcam testing is switched off. And as soon as I did that, I got connected. Thank you. And to now, I mean, in this forum, there is a lot of emphasis on our sharing of our experience and knowledge on stroke with the public and public at large, as well as the stroke caretakers, and then stroke patients and stroke physicians as well. That way, I'm a little feel a bit constrained talking on a subject, research for stroke. But nevertheless, I think it has a lot of relevance, which I will try to convince you. And let me start by thanking the Health Alliance India, Dr. Ratna, and Madam Dr. Madhuri Bihari for giving me this opportunity to join you on this very important day to share some of my views on stroke. Now, see, the topic research for stroke is probably included by the learned think tank of Health Alliance because they have certainly felt that there are many areas of stroke where we do have a lot of dark zones of knowledge. We are not sure of things. And so though we do have quite a good amount of information on various aspects of stroke, and we are very clear about certain areas, and we do have sufficient knowledge in many areas, there are indeed always and always there will be indeed areas where we still want to improve or we still remain ignorant, and which is good, because only if that's the case, we will be able to continue to do better care for our patients and will be able to better take care of our own health. Can we go to the next slide, please? Right. So let me start with the first question. Usually when we talk to people about stroke, many people, even many learned people, have some confusion whether it is a disease of the brain or the heart. This may look a bit funny, but even among educated people, this confusion I have seen. And but there is some relevance also. Both are diseases of some diseases to do with the blood supply of vital organs. Now, coming to the science of it, is there any, if you are taking care of your heart very well by taking care of your blood vessels supplying your heart, are you sufficiently taking care of your brain as well? Are you protecting yourself from stroke as well? Well, this may look very logical to say yes, but we do see in our own practice that there are a lot of people with a very severe coronary disease and all, but they remain quite good intellectually, and somehow the brain is protected. But we also see people with strokes who doesn't seem to be always having coronary disease. So are they very similar, or there are some differences? So we all know that reducing cholesterol level, especially the LDL levels, is quite good for coronary artery diseases. But statins are, of course, there is some controversy which has come up now, but generally we do feel that statins are quite good for reducing cholesterol and maintaining the health of the coronary arteries. But when it comes to brain, there are some issues. You know that there are several studies like Sparkle and all which have shown that lowering cholesterol too much can sometimes predispose to bleeds in the brain, and also there could be the myelin, which is the insulations of the connecting tracks between the nerve cells and the neuronal pools, also need a lot of fat. So the aggressive cholesterol lowering may not be all that good for brain as much as it is for heart. So what are the differences? If you look at it, again, there are plenty of studies. Homocysteine is an area where I did my own PhD work. And one thing which was becoming more and more clear, even from, if you look carefully at published data on homocysteine from anywhere in the world as well as from India, that high homocysteine is actually certainly far more bad for brain than for the coronary arteries. So there is, after all, some good in giving the homocysteine lowering vitamins like B12, folic acid, which we neurologists keep on prescribing, and cardiologists do it much less often. There is some scientific justice in that, though B12, all these B vitamins were usually given thinking that it's better for the neuronal health. There are also many other differences, genetic differences also between the blood vessels of the brain and heart. And this is a very aggressive area of research now. And I'm sure that we are going to get more and more information in time to come. Next one. Yeah, I think the slides I can see in my presentation quite well, but are you all able to see the slides clearly, the letters and words?
No.
Are you able to see them clearly on your screen?
No.
Can somebody do anything? This is a PowerPoint slide which is very clean and clear, in which I am having, but here I do see it, the letters are quite unclear. So is there a way I can present from here and to try that, or shall we go ahead? Okay, I will, because I am not seeing these slides which are coming in front of me quite readable. The words. Right, okay. So the other important question is, what is the best minimum dose for a very common but very important drug like aspirin for stroke? Is it, we have studies on 325 milligram, 300 milligram, 150 milligram, 75 milligram, and the mini pill 50 milligram. There are advocates of 50 milligram, but even now, even recently in acute stroke, at least the immediate ischemic stroke, the drug, the dose which you have to give it is a slightly higher dose, 325, 150, etc. So the problem here is a concept called aspirin resistance, which is very, very, very difficult to actually quantitate and to even confirm in a person, because biochemically it's a very challenging area. We ourselves try to do this, and we found out that there are a lot of technical questions and technical problems. So the ideal and the minimum dose, we don't want to give too much of aspirin and prod the internal linings of our stomach and intestinal tracts. But at the same time, it should be good enough to prevent platelet aggregation. So what's the ideal dose? This is a question, and even somebody gets and again, to compound, we get stroke after on aspirin. So should we increase the dose, or should we add on another antiplatelet drugs like clopidogrel, or there are other ones like dipyridamole and astimizole and all? Should we try these things? Actually, despite quite a lot of research going on and our full faith that aspirin is good, it prevents platelet aggregation. We still do not know what is the best drug. Should it be individualized? Is there a way to individualize? I'm sure there must be. The personalized medicine is coming up in a big way, and we must be able to find out whether will aspirin do good to an individual? You saw at what best dosage in primary prevention, does it have a role, or whether, and when you are giving it as a secondary prophylaxis after somebody has had a stroke, what dose should we give and how long we should give it at that initial, perhaps higher dose, and then what is the maintenance dose? So these are areas which we still need to ask questions. And suppose you're thinking of a drug like clopidogrel, again there are problems. I hope many of you know that around 30% of the Asians have CYP2C9 and CYP219 C19 mutations. These are studies even from JIPMER, and we have many other reports. There are a uniformity of results telling that around 1/3 of the population are actually cannot actually metabolize clopidogrel to its active ingredients. So it doesn't work. Then why are we giving clopidogrel without even checking that? Ideally, we should have certain, and these polymorphisms are not at all unusual. Around, around 20 to 40% of the populations can have this polymorphism. So it's important that we check for it if you want to give a drug like clopidogrel, which has got, that there are some problem with blood counts, etc., and people develop anorexia and several issues with clopidogrel. So we had, and this will also encourage for not stopping just with the clopidogrel, just because we had a few trials like CHANCE, etc., but we should continue to look for better drugs. There are drugs like astimizole, and so we have to continue to look, and the newer drugs like abciximab, which we are scared because we think that it's a bit too dangerous unless you have a stent, etc., on you. So we have to continue to look for better antiplatelet drugs and the best dose, and to who all we can give. Some kind of personalized medicine may be needed here. Next one. Yeah. So again, anticoagulants, stroke patients with the cardioembolic stroke, classically the people with atrial fibrillation are put on anticoagulation to prevent second stroke.
Dr. Sunil, I'm sorry to interrupt you. We are running late. So I would like you to, shorten your talk a bit if you can.
All right. Okay. So I'll go faster. So this is another area, and we have a problem of rheumatic valvular heart diseases. And the ideal drug dosages for rheumatic valvular heart disease, when a lot of new anti-arrhythmic drugs, new anticoagulants came, like the factor 10 inhibitors, dabigatran and avaroxaban, and a large number of these drugs are available in the market, and they are produce less of bleeding, and they are less renal and hepatotoxic. But are they good for the commonest cause of atrial fibrillation in India, that is rheumatic heart disease, rheumatic valvular heart disease? We still don't have evidence, and developing countries where rheumatic heart disease is common have to pursue this. There is some attempt from ICMR-based studies on this, but for some reason it has not taken off. Next one. Oh, right. And we all know that in a large middle cerebral artery infarct, decompression helps. And it previously thought it only saves lives, but we know that in the long-term outcome is also help. But do we have the same advantages if we do the decompression for the posterior fossa? Does it also help in a long-term prognosis? We still do not know that. Next one. Suppose somebody has got a very critical carotid stenosis, more than 80%. Usually, and if they had a minor stroke on the same territory, we have to either stent or we have to do the carotid endarterectomy. That is the current, the NACET and ECST studies have very clearly proven this. But what if the infarct is on the opposite side? Or the suppose the patient has had a large infarct, does it always mean that we should never do anything more on that tight carotid artery? So we have to actually study the hemodynamics. We have tools now. And so many of these indications for carotid endarterectomy are going to be rewritten in time to come with better information on the hemodynamic status, better better vascular physiology and rheology information. So this is something which is going to change sooner rather than later. Next one. In major artery stem block, again, we usually mechanical thrombectomy is actually the preferred treatment because if it thrombolyzes, it can turn hemorrhagic. But at the same time, people think that if the center is too far away, can we actually do a bridging thrombolysis and then shift? Or should we directly shift so that we save the time of thrombolysis and then do the thrombectomy as early as possible? Still, this area is not completely unanswered, but fortunately, there are a lot of trials going on in acute centers on this. Next one. We don't have somebody, if somebody has already had a stroke, and if they come after the thrombolytic or thrombectomy windows, unfortunately, we don't have any neuroprotective drugs. We have thousands of drugs which proved absolutely amazing at animal experiment level, but none of them translated into human trials still. Is it because animal models were bad, or is it because the technology, they didn't do any randomized control trials, so the methodology of stroke was bad? Or because humans are very, very different from other animals? We need to really do some good research here too. I'm sure there could be neuroprotective drugs emerging if you do this properly. Next one. Next one, please. Yeah. Now, when we think of physiotherapy, we all know that we are all happy to have physiotherapy to give to patients physiotherapy, but how much it actually makes a difference? Actual quantification of physiotherapy related improvement is not clearly known. It doesn't do any harm, so it's always given actually. But we also should try to quantify so that at least between the different measures of physiotherapy, we can really find out which one is better compared to the other ones. Next one. There are newer techniques, fancy techniques, some might like to call it, like direct current stimulation, transcranial magnetic stimulation, facilitation of the affected side or inhibition of the unaffected side so that the affected side is stimulated to work by itself better. There are a lot of research going on in this area, people using different types of protocols, but we don't have uniform protocols which has emerged as good working models. to go into guidelines. So this is an area where we still do not know. A lot of CAC therapy is going on, people making money doing all these things. So we have to be guarded, and we have to try to see whether this is effective or non-effective actually, and if it is effective, what are the best protocols. Next one. We in India, we have a lot of traditional medicines, and many times there's a huge divide between, and there's always some fights also between the traditional physicians and the allopathic or modern medicine physicians. And this has actually alienated the medical scientists from exploring deep into the herbal medicines like Ayurveda or maybe Unani or Siddha medicines. We need to scientifically test these drugs because huge amount of money is being spent by people on the other medical, other conventional medicines. They are costly also, and even government gives reimbursement. So how good they are? Are there any of them bad? Should we take them out of the market? It's difficult, but then there should be an attempt to do this. Artemisinin came from Chinese herbal medicine. They tested it scientifically, and they proved it is saving millions of malaria patients now. So we need to very urgently look very carefully and very scientifically into many of these tropical herbal drugs abundant in India. Next one. And we have traditional practice like yoga, meditation. Everyone says it's good. I have not seen a paper telling that these are all bad. But scientific evidences, if you look at the papers, scientific quality is always questionable. Most of these papers, that doesn't mean that they are not bad, but there is a need to very carefully evaluate, to quantify, and to find out which of these yoga practices could help, which could actually endanger, because there are some of the practices which produce a lot of hyperventilation, produce vasoconstriction, etc., to the brain potentially. So are they really good? If so,
What happened to Dr. Sunil? Is something problem with his, maybe? So, what shall we do?
I think he lost his connectivity.
So
I'm thinking.
Speaker is Dr. Sriram Vardarajan, and he's consultant neuroimaging and stroke at Coimbatore, and is also a stroke survivor. So I think we'll be able to hear something firsthand from him. Dr. Sriram Vardarajan.
Good evening, everyone. Am I audible?
Yeah.
And hope my thing is audible. So the topic given to me was to speak on something called a referral pathway. Do we have a robust referral pathway available in India? And is there a continuous process that is there towards providing the best outcomes towards stroke patients? To be really honest, the answer is no. But I think it's better that we can go on a positive note to first understand the pathway available first, and the need for a referral pathway, and what is this kind of life cycle approach towards stroke itself. My affiliation is always not towards neurology or radiology, it's always towards stroke when it comes to discussion like this. And from my own personal experience over the last maybe 15 years or so since I've done my medical schooling. So can you have the next slide, please? So as we can see, the pathway starts with the patient coming to the hospital with the first onset of stroke. Although this is not ideal, the pathway should begin with prevention, but invariably that is never the case. We always realize it later that we had a lot of lifestyle factors that went wrong. We just couldn't get time to spend time, importance to our own bodies, and stress levels these days are kind of increasing day by day. So we eventually start off with a patient coming to us with stroke, and that is kind of the hyperacute phase. And all that we can do at that time is to ensure that the damage is as minimal as possible, which means we just have to hope, one, the stroke is a minor stroke. But if it is a major stroke, what are the things available at our disposal to reduce the extent or the severity of its impact? Because the initial onset can be severe, but we have a time window, albeit a very short and narrow window, to reduce the damage. So we have to rush the patient quickly to an imaging, and then we have the treatment options broadly categorized these days as thrombolysis or thrombectomies, which means either you dissolve the clot using a lytic drug, or you go inside and remove the clot. And we're talking about an ischemic stroke. And unfortunately, science hasn't progressed so far in the hemorrhagic counterpart. And all that we have at our disposal is quality nursing care, control of risk factors, and hope that we can rapidly reduce the amount of damage by reducing the amount of bleed. So ischemic stroke is what most of the focus lies on, even in the previous discussions, in terms of all those establishment of telestroke units, trying to get government hospitals to provide thrombolysis. The focus is out and out on the ischemic stroke, which is kind of okay because it constitutes the majority of the stroke. We're looking at maybe an 80-20 ratio, and the 20% that is hemorrhagic stroke, and they start off as a stepbrother. They already start off with probably not being able to get the same outcome as an ischemic stroke. The stroke unit is a very important concept and probably one of the best proven concept, the earliest proven concept that creates a change in outcomes. And we just hope that every city, every district, and every even a village can in due course have a small stroke unit. And it doesn't take a lot. We're talking about at max maybe 4-bedded, 6-bedded, without a need for a ventilator, with just monitoring devices. And then we move on to the specialized assessment and the most neglected part of it, which is the post-stroke therapy. Yes, we do the lysis, we remove the clots, but what about the majority who are not candidates for this acute therapy? And I tell you, at max, the best of the best centers across the world, they can hope for maybe a 20% thrombolysis rate and a 10% thrombectomy rate, which means that we are not again catering to the remaining 80% of it. And that is the sad situation. And that's where the post-stroke therapy plays a huge, huge role. That's where all the occupational therapists, the speech therapists, the physiotherapists, the speech and language therapists, all of them, it's a complete multidisciplinary team approach. And it starts from the day the patient suffers a stroke. We all know that virtual reality augmented programs nowadays can even improve their outlook towards stroke recovery. It can be done even when the patient is lying in the ICU bed. And let's not make it very hi-fi. Every patient affords a smartphone these days. We're not talking about a high-end device with providing a virtual reality system. Let's not even go there. We are in India. Let's have a simple phone that is available there to be shown videos of what the patient wants to see, not what the doctors want to show. It should start with a patient's perspective. And I will show that in the subsequent process. How do we take the cycle and place the patients in the center of it? And finally, we discharge them. Majority of the times, we say functional independence. We use complicated scales. We say MRS. All that we want to know at the end of the day, can he do his day-to-day life? Can he continue with his previous life? How much are the restrictions and what are the things to be changed in his lifestyle? And this has to be a continuum because the patient has to be told, this is your expectations at 3 months, these are your expectations at 6 months, provided you fully cooperate with the rehabilitative process. And how do we develop a system to ensure that this process happens, at least to the most optimum levels? And that's where most of the bottlenecks are. And finally, if all of them goes well, and if the patient cooperates, and most importantly, if he has a supportive system, the importance of family. We saw that in the ATTEND trial, very, very important trial conducted here in India. And family-led rehabilitation. Unfortunately, it wasn't positive. Doesn't mean we let go of it. it is still probably our best methods to provide a better outcomes to majority of the stroke patients by teaching and training the caregivers, the patient's relatives. Because even now studies have shown some of or most of them tend to live in joint families. It's not the case in big cities, but we go down to tier 2s, tier 3s, the villages, we know the local people are out there to help. How do we use that? India's greatest gift would be our manpower. So how do we use this manpower in each of the settings across a continuum? Can we move on to the next slide? So this, again, I've looked at what other countries have done. And this is just to understand what they have done. We can't keep catching up to the West. It's high time we think ahead and look at showing the West what it has done our way and what works for us. They don't have an Ayurveda. They don't have traditional medicines. They don't have a joint family system. I mean, some of them do have, but I'm saying the cultural practices that we follow in India are so vastly different, and we follow a westernized pattern of medicine. Yes, it is evidence-based. How are we going to apply that, and how are we going to use it for the Indian context? And that is probably the most challenging aspect of it. This is a very simple iconographic that I could find on the internet. The steps in onwards have already dealt with the steps, but this gives you a feeling of the magnitude of the problem we have. This is not a single step problem. We are talking about pre-hospital notification. We are talking about coming on time. We are talking about reaching a correct hospital on time, getting this imaging done on time, and hopefully he's a candidate for any of the lytic or the mechanical therapies. And if not, giving him the best possible stroke unit therapy with an assisted discharge plan. If it sounds so exhaustive just to speak, imagine to the patient what it means. And these are certain things that has to be made clear both to the patient if he is comprehensible and to the families at the doorstep of the hospital. You're going to say this is a process because the common thing that we encounter here, even here, sir, can the patient be all right? We are not fixing a mixer or grinder here. You're talking about human. You're talking about organ systems. You're talking about multi-organ involvement. If the stroke comes, obviously maybe he's got risk factors that is going to also affect his heart, his peripheral arteries, maybe his eyes. So we are going to talk about making the best possible outcome for him when he comes with a stroke. And I would probably insist that it's better that he never suffers a stroke in the first place. Can we go on to the next slide? Yeah, the next slide. So this is again a system that is being followed. I could find on the internet in England. This is in the Greater Manchester City. As we can see here, they have concentrated on incorporating the patient and caregiver groups and getting them into policy making. And I think it's high time we start doing that. We are moving in the right direction. We have a National Stroke Association. We have got a whole panel of stroke champions, the strokeologists in our country. Okay, but we need the champions from the patient group. We need the champions from the support group. We need the champions from the rest of the departments, not just the neurology. We are going to look at internal medicine, emergency medicine, imaging. We're going to look at the rehabilitation team. They form the fulcrum, the core in which we ensure good outcomes. Let's not lose the forest for the tree. We cannot keep focusing on lysis and therapy alone, not just mechanical thrombectomy. 80% is what we're looking at the rest of the picture. You can see they just had simple methods of 4 or 5 steps, not much, where they could integrate the networks. So if you can see, they started off as something called an SCL or a strategic clinical network, and they converted that into an occupational delivery network. England system works because they have done something called centralization. They have understood for their population and their kind of situation, it's best if a patient goes to a certain hospitals, depending on the area involved. So they've got hallmarked some hospitals called the hyperacute stroke unit or the HASUs. And they have a network of 4 or 5 HASUs in one place. And it's going to be that a stroke patient within a certain kilometer distance of that goes to this HASU. And they are even struggling to provide the thrombectomy services because the numbers required are so high. They have a fixed rota for working. Indians work day in, day out. We don't even know the concept of 8x5. So, and the manpower, imagine what we can do with that. So they have just simplified it into prevention, reorganization, optimizing the ambulance. And in India, unfortunately, let's look at the picture. Majority of them come in their own vehicles. So how are we going to educate them? Certain times calling up an ambulance is quicker. An ambulance gives a free path in the roads. Our people are now educated enough to make sure the road clears up. Obviously, if it's going to be a high density traffic network, it becomes a problem, but it's not impossible. They have done improvements to their inpatient care and finally to their community rehabilitation. They have started with prevention and they have finished with rehabilitation. And I would want us to focus on all these simultaneously, because otherwise we'd be playing catch up. We would just keep following one by one what they did. We could even watch what they did, what was the outcomes, and then incorporate the final outcome derived metrics into our context. And that would what I would encourage. Can we go on to the next slide, please? Yeah, and this slide, unfortunately, I mean, I had animations. I think when I gave the slides to them, they've taken off the animations. So these are two animations. The ones that is on the background, I actually talked about how a US-based system is available. They call it the Allied Health Assistant, which means you have an health assistant who is not exactly a doctor, but he can be a bridge between the clinician. How he works is they ensure that the rehabilitation is done in teleconsult with the expert. So it's not possible for a strokeologist to go and visit the home of every patient. But what can be ensured that we develop health assistants? When an election comes, we've got volunteers. When Corona struck, we had volunteers. So why can't we have health assistants volunteering for work in every network, in every district and every village? And we can make use of the youth force that we have. And they all have phones and they can be trained and they can do the rehab and they can find if it's going to be on track or if it's going to be certain new problems that have come up. A simple blood sugar, a pinprick is not something that is rocket science for them to learn. So they can measure the sugar levels. They can measure the BP. It's very simple. And the allied health assistant that the US system follows is something that what we follow as ASHA. So we have to magnetize that and give them incentives for doing much better work in that. The second picture in the background, which is not seen unfortunately, is a stroke or competency pathways, which means everything that we initiate needs to be audited. In India, it's easy to start something, but it's very difficult to hold somebody accountable for it. So we need to understand roles, we need to understand profiles, and we need to make that communication very clear. We're going to start this hope here. And if you're not reaching here, fine. Why did we not reach here? And it's not a blame game. And another thing that we see often in our setup is whom can I blame for failures? In research, failure is a norm. It's just a stepping stone for success. So we have the previous speaker talking about stroke research and the lacuna in that. But one of the most important things we have to understand is to accept failures, is to accept that this is a system we live in. There are certain things that takes time to change. It's not impossible, but we need time to change it. And the last figure on the right was about the models that are followed and practiced in the lower and middle income countries. We have something called an hub and spoke model, major hospital, minor hospitals. And are they equipped to treat with certain kind of patients? We have the ASHA models. We have the multidisciplinary team care. We can even have teleconsultations between an hospital, let's say in Ludhiana, and another hospital in Asin. I'm taking this example because it's already being done. And I was fortunate to work with the person who initiated a lot of epidemiological work in the last decade or so, Dr. Jayaraj Patel. And you can go through his works available, and he's probably there in every panel and trying to push forward this kind of hub and spoke models, trying to get the peripheral hospitals, equip them, train their staff. We don't need specialists everywhere. We can train them to become specialists. It's not that difficult. So the second part of the diagrams there is actually talking about the structure that we need, the process that we need to follow, and the outcomes we need to derive using these processes. I won't delve too much into it because of lack of time. We can move on to the next slide. So these are the dimensions. This is what we need to plan for the next 2 years, 5 years, 10 years. It's not going to be a day or a month plan. Can you come to the next slide, please? Yeah, and finally, we have all these systems of care, which places the physician at the center. When do we start placing the patients at the center? And we're not talking about, even a village person has aspirations. He wants to go back to the field. He wants to hold a shovel. He wants to know whether he can work the field. And then we have got the other extreme, the Google educated people. They know everything that is there to learn about stroke treatment. Do they spend the same effort in prevention? I'm not so sure. Yeah, but they do come to us. They have aspirations. So when a patient is lying in a stroke unit, when a patient is lying in the ICU, what are we asking him? Are we even asking him what are his dreams? What are his aspirations? How realistic it is? We don't want to sound pessimistic. And we can have counseling sessions, the psychosocial workers. And we don't see that happening in our Indian hospitals. I go to Singapore there, they have a family-led counseling session in a stroke unit. So they have a separate counseling room. So you have, yes, we do make our rounds. We do go back and visit patients. But why can't that be combined with a counseling session? That takes both the patient's perspective, the caregiver's perspective, and a reasonable healthcare objectives over a respectable time frame. An IT person coming with, difficulty in moving the hand, he might still be acceptable to moving around in a wheelchair, but he wants to use his hand, or he wants to use his speech if he wants to use a dictaphone. The question is, are we focusing on the goals rather than focusing on making him right fully? That is a very difficult challenge, but getting his goals is probably a more reasonable and acceptable challenge. And this is the entire focus of this slide, getting the patient and probably I should say the caregivers in the center. Can you move on to the next slide? And what is the treatment burden? This is actually very interesting. It's just unfortunate that I'm not able to see what are the individual things that is out there. It's actually a theory-heavy slide, probably the only theory-heavy slide in my presentation. But this is a very interesting article that I could found on PLOS-ONE, and it's from a UK group. They don't consider a burden of treatment as just medicines or even the rehab. They take in the social aspect, the mental aspects. So it starts with what does the patient make sense of all this? How does he plan and care for this? And what are going to be the steps in each one of that? So how does the patient interact with the physician? How does the patient interact with the rehabilitation person? Everything is a burden. Everything is a treatment. You spend 2 minutes talking to the patient. That is considered as a treatment. It is a burden to the healthcare service. And how are we going to estimate the cost of this? And that is going to be the biggest problem. We can cost estimate the drugs. We have papers that say the average stroke unit stay is maybe around 5 to 10 days. The average cost involved is maybe around 80,000 over 6 months. And these are very well-researched papers. But do they account for the mental aspect of it, the psychosocial aspect of it? And those are things that we need to start seriously looking at. Get feedback from the patient. How was their perspective changed post-stroke? Okay, and what does that mean for the rest of the family? Maybe I'm a father of 2 daughters. A daughter sees the father as the hero of their lives. And if the hero becomes bedridden, what is going to be their perspective? How do we take accountability and how do we estimate the cost of these things into our framework of cost estimates or treatment burden? And that's what these slides deal with. So I will not go into the individual thing, but we need to understand the treatment burden is a continuum, just like care is a continuum. Can we go on to the next slide, please? And these are the studies that I told where the hospital costs are actually being determined. And there are simple studies, there are complex studies. We have the systematic reviews, and all of them point towards the same thing. Average hospital stay, 5 to 10 days. Majority males. I can bring a perspective into this. Why do males come? Is it because the females are neglected? We are a patriarchal society. So does that mean the stroke in females don't reach the hospitals? How is that we have every study showing a 70-30 female male preponderance, while the age group is 60? Yes, we know that menopause and other hormonal influences play a part. But with the mean age or the median age being 60, every study shows a male preponderance. So is it in India? I'm talking about Indian studies. And is it in India that, females are neglected? Is that a real issue? We're not sure. And they have a totally different perspective. A male needs to go to work. If the female cannot work in the kitchen, the entire family suffers. And we have seen instances where they tend to work with one hand, continue cooking, while the other hand is paralyzed. We had even videos when Corona came, people, working with oxygen masks on their face. I would say that these are unique perspectives applicable only to India. The gender bias and the urban-rural bias, the divide in them that was spoken about previously. So those are issues that are India-specific. And we need to start focusing on them, not following blindly what the Western medicine and evidence says. Go on to the next slide. Okay, again, this is the same. It's just that over 6 months, it's going to be 80,000. But if it was a major stroke, even an acute hospitalization is going to cost you the same. The average thrombectomy cost is upwards of 2 or 3 lakhs. Why aren't the stents being placed as emergency medicines? Why are they not come under life-saving drugs? Why aren't thrombolytic drugs being given free of cost in every state? Some states do give it. So we are making progress, and we should continue making progress. The thrombectomy devices should be brought under the ambit of life-saving devices. And they should probably have a ceiling, or at least the government should provide packages. We don't want private hospitals to refuse a thrombectomy for want of money, for financial issues. Because by the time they reach the next hospital, the time is gone. I wouldn't blame the private hospital also, to be really honest. And the government the onus lies on the government to ensure that we have a separate funding available for such patients. And the other downside being, are a specialist available in every government hospital? It is not the case. So why aren't we having a government-private-public partnerships? Why isn't every state looking at models where they can send government patients to a thrombectomy center and back again? And the procedure is going to take 2 hours. So let the staff stay with them, come back to it again. They can be trained, whoever is interested in the government setup. I work in a private setup. And we would love to collaborate with the government people. When I was in Ludhiana, the general hospital there didn't have a CT machine. And they had a tie-up with CMC. And these are good initiatives. These are very, very, prospective procedures on things that are more progressive. Next slide, I'll be finishing this last couple of slides. Yeah, so this is couple because there are things inside this. So WHO in 2018 brought this initiative, and it's called the patient-centered or a people-centered healthcare services approach. And they are focused on 2 things, something called a continuum and coordination, a care continuum and care coordination. And I think that is most suitable to stroke services. And that can only be possible by bringing all these stakeholders, creating a vision, creating a target plan over short term, medium term, and long term, getting all the champions, not just from one sector, from every sector, including patients, and then daring to transform the situation. We don't have to follow the West. We can show them what is possible. And I would end with that. Thank you so much.
Thank you very much, Dr. Vardarajan. You have touched so many aspects, like what are the things that we can take to our Indian scene, the models, and other things like when to start therapy and so on. So our final speaker is Mr. Samir Bhide. He's an author and he's also a BCom graduate from Mumbai. He's done his master's degree from USA, and he has also worked at Boston and also at Vienna. He is spent his 24 years in different roles in management, technology, consulting, knowledge management, and sales at various places in India and abroad. He is also a stroke survivor, and he's going to talk about his experiences and what can be done for the patients who have Parkinson's disease. Sorry, who have stroke. Mr. Samir.
Thanks, Dr. Bihari, for the kind introduction. And thanks to Stroke Support Alliance, for giving me this opportunity to be on this panel. I'll try to go as fast as possible to catch up on time, but I will make sure I talk about the point I want to stress. So productivity post-stroke, right, is very, very important to heal, because this is a trauma. This is a big trauma for anybody. So getting back to where you were, or at least some part of it, is very important. And it's just not for you to be able to do some of the physical activities, but also for your mental and emotional well-being. So it's very important for your independence. Very important not to feel guilty that you're dependent on someone. So productivity is very important. And before I talk about how support groups help, I just wanted to stress that support group is one of the tools we have to help us heal. You obviously have to do a lot of other things as well. So whether it's a traditional therapy methods like physical therapy, occupational therapy, speech or language therapy, cognitive rehab therapy, and stuff like that. You got to do that. As well as you have to experiment doing alternative treatments and therapies. Yoga, meditation, Ayurvedic diet, massages, and music therapy, which I found to be very, very useful. In India, I've done rehab with raga therapy. And over here in the US, I'm doing something called whole tones, which is a high frequency music therapy. So it helps with your brain. And it's not just the Indian, treatment and therapy. There are also lots of other holistic treatments like acupuncture and etc. And the last part is you have to take care of your mental and emotional health as well. So not just doing traditional physical therapy and alternative therapies. You got to do things like talking to a clinical psychologist. I think somebody mentioned that before. It's very, very important to do that. And I never did that before my stroke, and I did that after my stroke, and it has helped me a lot. And the other thing, like music, which is healing, is writing or journaling. And it helps to put your thoughts on paper. It helps to talk about, write about it. Whether it's in my case, it was a book. Whether it's a blog, whether it's just your diary or a journal, whatever. Writing is definitely a healing method. And the other thing is volunteering. What has helped me and what will help you is volunteering your time to do other things, right? So like I'm volunteering at a few places. I volunteered at the hospital where I had my surgery and things like that. So that helps you with the mental and emotional peace that you're making a difference. So lastly, right, joining a support group like the Stroke Support Alliance is exactly what one needs, and it helps you with mental and emotional support. And obviously, you're promoting, you're raising awareness, like we are raising awareness about stroke in Stroke Support Alliance. But more importantly, you are sharing your experiences and practices with others, which have worked for you. And hopefully that will be helpful to others. And at the same time, you get information from others who are in the same boat, whether caregivers or stroke survivors, and what worked for them. So it gives you, possibilities. I call it discover possibilities. In business, we call it art of the possible. And Stroke Support Alliance and groups, support groups like that are a safe place where you are not judged. You are accepted the way you are. It helps you accept your new normal, because post-stroke is an absolute new normal, no matter what kind of stroke or what you have. It's a new normal, and joining a support group helps you, accept this new normal further. And you can, you can see others who are, doing well, and the fact that they have a life after a stroke, and that gives you a lot of encouragement. And the other thing which I find, support groups useful is, it's good to get things off your chest. So there are certain things you cannot ask others or whatever, but I think the support groups gives you a forum to ask those things, and you don't feel, odd asking questions. So support group is like a family. You feel the belongingness. It's like a community, and it's like a family type community, because post-stroke recovery is very, very lonely. You are cut off from work, friends, and activities. So this feeling of belongingness is very important. And Stroke Support Alliance, I'm very thankful that I'm part of it. And I feel the group is like a family, like a community. So let me just talk about what support groups are not. It's important to know what support groups are. It's important to know what support groups are not. They are not substitute for professional care. So you may hear different ideas and things, but always remember that they are not a substitute for trying out things on your own, or, You still have to see your doctors and your care providers and so on. And also, they don't have any magic pills. There's no magic formula they have that will take care of your situation. It gives you ideas, it gives you experiences, and you have to try it out with professional care. And the other thing which a support group is not, it is not a place to complain or bash others or other thinking and stuff like that. It's a place to learn. A place to learn, from others, share your experiences, and so on and so forth. It's not a place to complain. And the other thing which is important for everybody to remember, including me, that it is not forever, right? Stroke support groups are formed to help you face and overcome your challenges post-stroke. So at some point it has to stop, right? And that's an important element, because I know some people who are part of support groups forever, and that's not the idea. And again, the other thing is, it's not a place for everybody to jump in and talk and have their opinions. It's not a free-for-all. It needs a good facilitator or a moderator, like we are lucky to have Tamanna in our group. And again, it's not a place only to talk and opine, like we do on social media. It's a place to listen, listening to others, offering encouragement, offering motivation and stuff like that. And the last thing is, when you're part of a support group, don't, they're not there to compare your situation with others. You will heal your way and at your time. So it's not a place to compare. So Dr. Bihari, those were the points I wanted to make sure about support groups.
Thank you very much. Your ideas are really very nice and very interesting, and they're quite, one can, equate and feel with the ideas that you have.
Right. Thanks for having me.
Thank you. Thank you very much. So I just want to sum up whatever we have heard over the last hour or so, or maybe a little more than an hour. This session has been very, very interesting. We had 4 speakers in this session, and we understand the need of education of masses, education of people who are not yet affected, and education of also people who are affected by stroke. Then and the education starts from prevention and not from treatment or after treatment. After the stroke has happened, it starts from prevention also. Then we need to have technologists who can prepare useful and affordable instruments which can be used, like prosthesis and robotic arms and robotic legs, so that people are able to move around for those who are not able to move. And there's also a paucity of personnel in different areas of which need to be provided to the person who has a stroke. These could be physiotherapist, occupational therapist, speech therapist, psychiatrist, physiatrist, psychologist, language experts, those who can teach music, and those who can teach dancing also. I think both of these activities are very helpful. As you pointed out very nicely, that speech helps. I also found speech is very, very useful when especially your speech becomes dysprosodic. There's no tune, no sort of melody in your voice. You need to learn some language, some music like ragas, which will help you to speak better. And we also should go back to the traditional medicines like acupressure, acupuncture, are medicines which are herbs, and are other Ayurveda and yoga, meditation, and so on. And there's a lot of things to learn from new research that can be done. And that, of course, will help in the patient care later, but it helps understanding the disease and how to treat the disease as well. And certain points which are raised by Dr. Sriram were very important. Like he said, the for any management of patient with stroke, the patient is the center of all the inputs which should move towards the patient, and we should always keep the patient and the family at center. And we are at a privileged position that we have a joint family system generally in not speaking in large cities, but generally in second and third tier cities in villages. Joint families are the norm. So the education of the caregiver is also very important. Another thing which I want to highlight here is that the architects there should be a person who should inspect the house of the person who has had a stroke to see what all changes needs to be done. For example, how the bathroom should be, how the kitchen should be, how the corridor inside the house should be, what the furniture should be like. Some patients have difficulty in getting up from low chairs, so we need to modify the sitting chairs, the sofas, the bed may be also such a way that it's easier for the patient to roll out of the bed and then be able to mobilize. So there's so many things that we need to address, especially if we are looking at the good outcome in a patient with stroke. Stroke is not just thrombectomy or operation or removal of the thrombus from the arteries. There are so many aspects of it and very nicely highlighted by all our speakers. So with this, I would like to thank Dr. Ratna, all our panelists, all our speakers, and also the people who are attending this, and WHO and the Stroke Alliance, Stroke Therapy Alliance, whatever is known as, and the organization with which Ratna is attached, which is Dakshayani. So I'd like to thank all of you. Thank you very much.
Thank you, ma'am. This panel was really fantastic. Thank you so much. We did receive a few questions, but in the interest of time, we will send the questions to the panelists, and we hope to receive your answers. So thank you so much once again. And with that, we move to the next section of today's discussion. And I would like to invite our last keynote speaker, Dr. Sanjeev Kumar. Dr. Sanjeev is the chairman and managing trustee of 3 Domain Health Leadership Foundation, and he's also the chairperson of the Indian Alliance of Patient Groups. He's the past executive director of National Health Systems Resource Center, Ministry of Health and Family Welfare, Government of India, and All India Institute of Medical, alumni of All India Institute of Medical Sciences, New Delhi. He's also chairperson, Indian Academy of Public Health, chairperson, Institutional Review Board at Gautam Buddha University, and he's a professor of leadership, global health and program management at England Institute of Global Health, New Delhi. He's worked for 22 years as a health specialist in UNICEF and various international assignments. He's a preventive and social medicine specialist and lectures in University College of Medical Sciences, New Delhi. Has more than 100 papers to his credit in scientific and popular magazines and chapters in books. Thank you, sir, for joining us. Over to you for wrapping up the entire discussion since morning, which is not going to be an easy task, but I know you will do it with elan. So thank you so much for joining us, and the floor is yours.
Thank you, Ratna, for that generous introduction. And I also thank your other team members, Tamanna, Ankit, Dabra, and many others who are behind the scene. You have been on it for more than a month, getting hold of each one of the experts. So excellent job done. You had gathered 14 experts, including the chair, each one of them renowned not just in India, but globally. So my task is very difficult because what they spoke, each word they spoke was pearls of wisdom and knowledge. So my task is to try and bring that together. I will do my best to bring it together, but I will start with nothing for us without us. That was one thing which came out very clearly. And in my summarizing across 5 broad areas, I will highlight that point because as chair of Indian Alliance of Patient Groups, I won't do justice to my job if I don't do that. The first area I want to talk about is problem and its pathway.
The problem of stroke in last couple of decades has gone up from the 12th cause of death in India to 4th cause of death. And it will keep increasing. It already contributes to about 2 million deaths every year and about 11 million hospitalization every year in India. It is already a huge problem which is increasing by the day. And if you don't look at the whole pathway, which starts with people who are healthy, they don't even have risk factors, you have to prevent risk factors in them. Then you have people with risk factors who are more likely to get stroke. You prevent stroke in them by taking care of the risk factors they already have. Then, of course, we have talked a lot about the people who have stroke. What can be done? So, and what can you do to prevent? Healthy dietary intake, maintain good weight, physical activity, control of blood pressure and control of blood sugar, prevent smoking and drinking, and stress, which is increasing by the day. I even hear 2-3-year-old children talking about stress. So that is going down to even children and everyone in the society. What we have to do is detect early and prevent early. And that is when we can handle. So that was point one, which is the problem and the pathway, which starts with keeping those who are healthy, healthy. Second is operational guidelines. We have the guidelines which many of the speakers refer to, developed in 2019, and I am told a revised version is going to be available in 2021. The globally renowned institutions such as WHO and National Institute of Health and Care Excellence of UK and many others have developed a clear methodology of how treatment guidelines, operational guidelines can be developed. In 2017, Ministry of Health developed this, what is known as method book. Unfortunately, this was not followed in 2019, and I am not sure what was the fate in 2021, which we will see now. You have experts, very renowned experts, and some of them were on the panel. But only out of 16 experts, neurologists, rehabilitation experts, and government officials. These global guidelines clearly state you have to include patients, you have to include bodies representing patients, you have to include caregivers, you have to include nurses, because they are the ones who are providing most of the care in the hospital. No, doctor just gives a prescription, but it is the nurses who look after stroke patient. Family member, they are giving care in the hospital if allowed, and they will continue to give care to these patients at home. They were not included. Primary healthcare physicians were not included. Everybody talked about starting stroke care from ASHA upwards. But why any one of them was not included in the development of guidelines? So that is on operational guidelines which we are following. Excellent guidelines. Another thing which many of the speakers refer to, whatever you include in the guidelines has to be evidence-based. As per ministry guidelines on developing guidelines, you have to give strength of evidence. They call it power of evidence. Do we have a strong evidence to promote an intervention? Is it plus minus, awaiting for more evidence to come through so that you can either include it in future or remove it from the treatment in future? So that evidence-based guidelines are very important for us to develop. This was the second on guideline. The third one is on hospital clinical level interventions. The speakers have talked about golden hour, getting the patient to the hospital as early as possible. Who is the one who notices the symptoms early? Patient and family members. Nobody has to. They started with Asha. She is not in the family. The first person to pick up any signs which could be suggestive of stroke is the family member. So they need to be the one who need to be educated, and they will take the patient. They will look for transport and then take the patient, maybe contact Asha if she is available, and take her help to take them to the hospital. Many of them talked about bridging the gap or minding the gap between patient and intervention, patient and doctor. I would go a step further, minding the gap between patient and intervention, because there are three types of delays when we look at emergency care. One delay is taking a decision to go to the hospital. If they are not available, aware in the family what could be stroke, they will not take a decision early enough to start moving the patient to the hospital. Second is transportation. Quickly taking them to the hospital and preferably in an ambulance, so that any life-saving measure could be done in the ambulance as the patient is being done. Third, even after reaching the hospital, I have been to All India Institute of Medical Sciences as a student, as a postgraduate student, and also as an attendant of a patient. It is a huge crowd in the OPD or in the emergency. It is very difficult for you to walk up to a doctor to get his attention. So it is not enough to get the person to the hospital. It is also important that after reaching the hospital, in the minimum possible time, the intervention is started. In the clinical care, we heard a lot about innovations. We heard about telemedicine, telestroke, teleradiology, palliative care. We heard about educating and preparing the family. There are many good examples. I heard first time about good palliative care in Kerala 15 years back when I was in Geneva. But why it has not been scaled up in the whole country? 15 years is a long time. So you have good practices, innovation, but they are not being scaled up. Why anybody outside Kerala does not have access to good palliative care? And I look at other innovations. So we need to look at scaling up the good practices and innovation, getting people who are doing this to meetings like this, to discussions like this is good. But somebody has to be held accountable for not scaling it up in the whole country. And that is what is lacking in India. I think one of the speakers said that we have good programs, we have good strategies, and we have good interventions identified in protocol, but it is not being practiced. Last beneficiary is not getting it. The fourth one is population level intervention. Care of stroke starts at home and ends at home. Those who survive come back home. So we have to keep the family in the focus, because that is where the care will be taken before the patient gets to hospital, to get the patient there in time, and after the patient comes back home, it is the family. And I wonder why people talk about patient-centric care. No, I am reminded of Mahatma Gandhi's quotation. I will not quote the whole thing. We are in healthcare system because of the patients, not the other way around. We are not doing a favor to the patient. He is doing a favor to us by giving us opportunity to serve. I heard many speakers say, patient should cooperate. His life is at stake. The family has a lot more at stake, and we are saying the patient should cooperate. I think the healthcare providers should understand the patient need and cooperate, so that you can provide good care, which we can call is patient-centric. The fifth and the last point I would say is financing. You look at financial allocation against what the government decided to allocate. We are not looking at the best allocation in the world. We are looking at what Government of India decided. In 2002 National Health Policy, they decided that they will spend more than 2% of the GDP on healthcare. When we were writing the next health policy, which was released in 2017, we were only at 1.1%. Now it has got a bit better. It is around 1.3% of the GDP. But 2017 National Health Policy says 2.5% of GDP will be spent on health the next year. 2022 is coming. And where are we? Around 1.3%. You have to have a big pie so that the allocation for conditions like stroke can be bigger piece of that pie. So that needs to be advocated very strongly with the government counterparts so that we get sufficient allocation. And of that pie, what is being spent on non-communicable diseases? I don't have figures for stroke. Till a couple of years back when I looked at the data, it is only 3% of expenditure on health, which is spent on NCDs, including stroke, including diabetes, including cardiovascular diseases and cancer. Only 3%. The government needs to give it a higher priority so that you can have more allocation and the pie gets bigger. Every one of these priority conditions can get bigger share of that pie. Insurance coverage is the last part of this financial allocation. There should not be a limit. I have seen personally in my friends and family who were hospitalized. One fine day, the doctor comes and says, you are being discharged today. And then when you go to the finance section of the hospital, they say, you have reached the limit. You have reached the limit of insurance for this condition. They won't get any more money. I think both private and public social insurance need to look at the condition and the treatment for conditions rather than putting the limit. The first question they ask when you go to private hospital, which insurance? And they immediately know how much money they can get from this person who is insured by a private or even by Ayushman Bharat. And that needs to be done. To end, I will repeat what our friend from WHO said, unite. I will change the sequence. I will bring integrate second. Third, educate. Educate is very important because it is the patient and the family who will take care in stroke or prevention of stroke. Fourth is treat. And we have excellent guidelines. We need to have resources for treating them. Fifth is fund. Without fund, money makes the mayor go. Without fund, you cannot improve care of stroke patients. Thank you so much. Over to you, Ratna. It was a difficult task. I hope I was able to capture most of the points. Thank you so much.
Thank you, sir. Excellent summing up. You made my job so easy. Now I don't have to do anything except call Tamanna and ask her to give her vote of thanks. So thank you so much.
And we can get input from the speakers when we draft this, because we may have missed some important points. Thank you so much.
Most certainly. Thank you so much. Tamanna, over to you.
Thank you so much, Dr. Ratna. As in the beginning, it was addressed by Dr. Ratna about the scholarships. So we are almost here to announce the names who have won the scholarship from the Stroke Support Alliance. So first is Miss Akansha Sharma. Second is Mr. Arvind Chittor. Third is the, just one second. Yeah, third is the Bhavesh Thakur. And fourth is Mr. Mohan Kumar. So we congratulate to all the 4 winners who have literally won their scholarships. Thanks, I congratulate to them. And now on the behalf of the Stroke Support Alliance and Dakshma Health, I would like to take this opportunity to thank all the speakers who have joined us today for the panel discussions and keynote addresses. It was a great pleasure to listen to your presentation and learn so much from it. Your presence and wisdom helped us increase the visibility of our cause. The rich discussions will be captured in a report and disseminated to all for the further comments. I would like to also express my gratitude towards the organizers, Dakshma Health, Indian Stroke Association, and Stroke Support Alliance, our collaborators, Healthy India Alliance, Indian Alliance of Patient Groups, International Alliance of Patient Organization, Patient Academy for Innovation and Research, and Mumbai Stroke Society, and especially our sponsors, BI, for their continuous support in making this event successful. I would also like to appreciate our stroke survivors and caregivers who have been constant motivation to us and have helped us with the numerous insights and experiences to shape the event to its current format. And I thank especially to all the participants who have joined us today, and I hope you have enjoyed these discussions. Now, we would now like to close the session, and thank you and stay safe.
मेरा नाम गीता है।
मेरा नाम जितेंद्र वार्ष्णेय है।
मेरा नाम शरद कुमार है।
मेरा नाम कामरान है।
मेरा नाम आशीष है।
मेरा नाम वरुण है।
और मैं एक स्ट्रोक सर्वाइवर हूँ।
मैं एक स्ट्रोक वॉरियर हूँ।
मैं एक स्ट्रोक वॉरियर हूँ।
और मैं एक स्ट्रोक वॉरियर हूँ।
और मैं एक स्ट्रोक वॉरियर हूँ।
और मैं स्ट्रोक वॉरियर हूँ।
बी का अर्थ है संतुलन। क्या किसी व्यक्ति को अपना संतुलन में कठिनाई हो रही है?
ई का अर्थ होता है आंखें, अर्थात किसी व्यक्ति को अगर देखने में परेशानी है, उसकी धुंधली दृष्टि हो रही है या देखने में कुछ भी देखने में असमर्थ है।
एफ का अर्थ है चेहरा। क्या चेहरा नीचे की ओर खींचा जा रहा है, मुस्कान टेढ़ी है और मुंह में भोजन नहीं रख पा रहे हैं।
ए का अर्थ है हाथ। हाथ या पैर में अचानक कमजोरी महसूस होने के कारण रोगी चीजों को उठाने में असमर्थ है, चलने या खड़े होने में असमर्थ है।
एस का अर्थ है क्या व्यक्ति के भाषण को समझना मुश्किल, क्या बोलने में कठिनाई आ रही है।
टी का अर्थ है समय। यदि आप इनमें से कोई भी लक्षण देखते हैं तो अपने निकट के स्ट्रोक के लिए तैयार अस्पताल पहुंचे। सुनहरे 4 घंटों के भीतर और अधिकतम 6 घंटे तक।
लक्षणों को पहचानें और स्ट्रोक को रोकें।
अपने लक्षणों को पहचानें और अपने स्ट्रोक को रोकें।
लक्षणों को पहचानें, स्ट्रोक को रोकें। लक्षणों को पहचानें और स्ट्रोक को रोकें।
लक्षण को पहचाने और स्ट्रोक को रोको।
लक्षणों को पहचानें और स्ट्रोक को रोकें।